Hello, hello, my friends. It's Jill Osborne from the Interstitial Cystitis Network. It is Sunday, November 17th, 2024, and it is time for another live IC support group meeting. Now, we're located here in Northern California in the heart of the wine country. And the best part about this season is that all the vineyards turn orange and it's just this majestical vision when you're driving through the wine country. But it's now legitimately very, very cold. Like we're having freeze alerts now. And so we have now entered the cool part of the year. Might surprise some people to know that sometimes you flare during periods of very, very intense cold or very, very intense heat. And that really is kind of a stress reaction. Hello, my friend Donna. Hope you're okay, honey. Can't wait to talk to you when you're ready. So anyway, it's cloudy, it's cool, it's getting ready for Thanksgiving, and like there's parts of this season that I love because I love being cozy, and I think that we as IC patients, we have to find our happy, and sometimes our happy isn't out in a big crowd. Sometimes our happy is home sitting in a recliner next to a fireplace with a cat in your lap, which is a living heating pad or just a heating pad, So I love the coziness of autumn. I just don't want it, of winter. I just don't want it to last too long because I need the sunshine to really be happy. But anyway, so my name is Jill Osborne. I'm the president and founder of the Interstitial Cystitis Network. I'm a live IC support group leader. I've been doing support group meetings for well over 30 years now. And I'm very, very, very happy to keep doing this work because I really like being a support group leader and I really like helping patients. It's what I do almost every day. Almost every day is I'm working with patients in need. Donna says she has an orthopedic surgeon appointment on Friday. You have arthritis in your hip and a trochanter bursitis. I will fill you. Girl, I'm telling you, getting older, I'm having issues with my left SI joint. So I feel your pain, my friend. I feel your pain. I'm looking forward to connecting with you. Hello, Anne. Nocturia, is it a medical issue or overactive bladder, contorting, or stinging nettle help? Nocturia means that you're getting up at night, many, many times at night. And it can be very, very disruptive because we need to have good REM sleep, and you're not going to get good REM sleep if you're getting up every hour to go to the bathroom. It's going to be very challenging. You have to remember that the human body needs to rest. That is when it rebuilds itself. That's when it heals. A good night's sleep is really, really important, and at the same time, really, really challenging for IC patients. And the answer is no. That's actually a typical sign of a very, very irritated bladder. We're going to see nocturia in patients with Hunner's lesions. We're going to see nocturia in patients with estrogen atrophy. We're going to see nocturia in patients with tight pelvic floor muscles, et cetera, et cetera. So that's just going to happen. I will say, in my experience, the patients who struggle with the worst nocturia are the patients who are not following the diet and they're putting acid in their bladder all day. And eventually, you got the distractions of the day. So it's a little bit easier to ignore your bladder. But once you're trying to calm yourself down and get ready for bed and you don't have those distractions, that's when you really feel your bladder. So that confuses a lot of people. Why does my IC get worse at night? And it's that your symptoms feel worse because you're not distracted by driving a car or going to work or working on a computer. You're just, it's when you feel it the most. So contorting or stinging nettle help? I don't think so. It depends upon the underlying cause. So as an example, if your nocturia is being caused by ischemia from very, very tight muscles, then your therapy has to be pelvic floor physical therapy. That's what's going to get you better. If your nocturia is coming from a thinned bladder wall, a dry bladder wall from estrogen atrophy, then what's going to help you is something that's going to coat and protect your bladder more. And that's going to be something with chondroitin. If your nocturia is coming from a neurological issue, then we have to do systemic things that will calm nerves down. Cindy says, thank you, Cindy. Matricia says, newly diagnosed with inflammatory arthritis. Could this trigger me? It's going to trigger pelvic floor. Like my SI joint right now is just, I like literally had some really, really good physical days this week from a pelvic floor standpoint. And then I literally was sitting here working, and I worked here straight for about 4 hours, got up, threw my SI joint out, and it's crazy. Hi, Renee. Nice to see you. Nice to see you, hon. Anne says, what calms nerves down? What calms nerves down are going to be things that relax your nervous system. So that's going to be things, good stress management techniques, exercising. Some people like meditation. Some people like yoga. I like painting. I'm doing a lot of painting instead. I will say that and I kind of want to talk about this a little bit later, but like, I just really feel like we're all so incredibly stressed out right now that it feels impossible to find peace and comfort. It does. It's just like everywhere we look, it's stress. And I really sincerely don't want to spend the next 20 years of my life feeling overwhelmed. So where is that overwhelm coming from? It's not coming from my health. It's coming from the media. It's just coming from this constant bombardment of wackadoodle stuff, whether it's getting online and seeing people fighting or politics or whatever. It's like, none of that gives me peace and nourishment. I think we all need peace and nourishment. I was listening to Pete Buttigieg was giving he was being interviewed on like Face the Nation or Meet the Press, something like that this morning. And he was talking specifically about how the way media works and the way bad actors in media work is they tell you bad things and they tell you good things. So they feed you scary, scary stuff over and over and over again. But then they also feed you good stuff over and over again. Like the same people will do that. And the only intent is to keep you unsettled. It's just to keep you unsettled and to help you lose your faith and to help you lose your confidence in whatever is going on at that point in time. And he said flat out, our generation, we haven't figured out how to do that. You know, he said, how do you find legitimacy? How do you know that what you're getting is real? And he said, in the old days, it was a signature. A signature, you know, that suggested that it was truthful. And then it was a picture. Once we had the ability to take a picture, if we had a picture of something happen, that implied that it was credible and truthful. And he said flat out, now that we have AI and pictures can be manipulated, how do we find truth? How do we find truth? And his answer was, understand that being online, it's filled with mixed messages and filled with bad actors. Doesn't matter what side. It's just the only reason online thrives is it keeps you upset. And when it keeps you upset, it keeps you coming back and makes you angrier and angrier and angrier and angrier. And he said, how do we fix that? Be with real people. Get back into your neighborhood. Go back to the gym. That's how you fix it. You connect with real people. So that's what you got to do. Anyway, listen, I'm not being political. That's just, how do we reduce stress? So I normally, when I do these meetings, I do a little 30-minute intro and then we take your questions. I want to talk about what do we do and how do we live with medications that cause side effects? And at what point are side effects harmful? And I want to share this because 6 weeks ago, I was put on a new medication because I had a little bout of AFib after I had my COVID vax. So atrial fibrillation. And the risk of atrial fibrillation is your atrium can develop blood clots, and then that can lead to strokes. And so they generally put you on a blood thinner. Well, I got to tell you, this blood thinner kicked my you know what. I have been nauseous almost every day since I started that medication. I might have one day out of a week where I felt good. Every other day, I woke up nauseous. The nausea got worse during that day. By the evening, I wasn't hungry. I was just so stunningly nauseous. I learned that I couldn't go walk unless I took the medication after I was done because it would give me GERD. And of course, these are really well known side effects of this medication. And finally, I mean, then I finally got to the point where I was just saying no to every invitation. It's like, I can't do it. I'm sorry, I can't do it. My friends wanted to go out to eat last weekend. I couldn't do it. I was too nauseous. My sister's birthday yesterday, I couldn't do it. It was just way too nauseous. And so I finally had a heart to heart with my doctor on Friday. And I said, listen, I can't do this anymore. I said, this has interfered with my ability to function. This has interfered with my quality of life. And her answer really surprised me. And I think one of the flaws in medicine is that you get a diagnosis, but they don't put it into context. And so, like, in my brain, I'm like going, oh my God, I'm going to have a stroke and die. Oh my God, because nobody ever said what my risk of a stroke was. They just said, you need to be on this for the rest of your life. And I'm like, what? Come on. I was in AFib for like maybe 3 hours, and then it went away on its own. And so I was kind of operating on the assumption that I would have to take this medication for the rest of my life. And I was deeply worried that it was imminent that I was going to have a stroke, right? Like, because they don't explain it to you. And then finally on Friday, she's like, well, we do it based upon your score, and your score right now is 2. 1 is okay, 2 is normal. Okay, a 1 is that you're a woman, a 2 is that you're over 60. I'm like, wait, you put me on this medicine, which is making me absolutely miserable. When every woman over the age of 64, 65 have this risk. And it wasn't urgent. It was never urgent. It was based upon a score that showed that I had a 2% chance of having a stroke due to my age, much less the AFib. The only AFib only happened once. We know exactly why that happened. And so I was just very blunt. I said, listen, I'm not doing this med anymore. I'm done. I feel terrible. And she's like, okay. It's like, you're not the only one. Lots of people have this problem. It's like, wait, what? And then she said, well, why don't you just take a low, one of those 90 milligram aspirins. And I'm like, what? I could have been doing that this whole time instead of being really nauseous all day. And she's like, yeah. It's like, oh my God. Wait, what? So anyway, it got me really thinking about this because when I got my pharmacology degree, which is a drug development degree, we talk a lot about how do you make medications, how do you develop medications, how should the patient respond to medications, and the really important role of adverse events and side effects. And the general rule is if a medication has interfered with your quality of life, if the medication is interfering with your ability to function and to work and do the things you need to do, that means that perhaps that medication is not for you. That you don't have to suffer with it. You have to go back to your doctor and say, hey, doc, here's the thing. This doesn't feel good. I'm struggling. And so I thought today I would go over the classic side effects that we see in a wide variety of IC medications so that you can think about, are you having a problem with that? And maybe if this is worth talking to your doctor about. So let's start first with Elmeron. So Elmeron, which tens of thousands of patients took from 1996 until a couple of years ago, is a chemical band-aid. It's a coating to the bladder. It puts a barrier on it. And so from a phenotyping standpoint, Elmeron was really good for somebody, say, with estrogen atrophy, where the bladder lining was thin and they needed a little bit of extra coating, a little bit of extra protection. Elmeron, though, it was notorious for side effects. It was notorious for stomach upset, diarrhea, sometimes diarrhea happening 6 months, a year after you start the medication. It was known for causing blood thinning and easy bruising. What were the other side effects of Elmeron? Easy bruising. And of course, now we know that Elmeron is associated with changes in the retina that could lead to blindness. And that is what we call pigmentary maculopathy. And this is, in fact, why Elmeron has fallen out of favor in the great majority of clinics because of its now very clear risk of eye damage, combined with now a very clear risk or a strong association with inflammatory bowel disease. So that's a part that's really interesting. So we've known from day one that there were some people who had problems with Elmeron upsetting their stomach or giving them diarrhea. And back then, what we were told is, tell them to take it out of the capsule. It was the capsule that was the problem. And so patients would then take it out of the capsule. Some got a little bit better. Some had no change at all, and they were still struggling with diarrhea. But we have multiple published case studies now that showed that once the patient stopped the Elmeron, the bowel symptoms for the most part went away. And so there was a direct link to Elmeron with bowel issues and stomach issues. And of course, now we know, thanks to the researchers at the Emory Eye Institute, they were studying the eye issues with Elmeron. They were the ones who were able to prove a very strong association between Elmeron and inflammatory bowel disease. Why? Because many of their patients had had portions of their bowels removed. And it turns out that Elmeron causes such a strong, it can, not in every case, it can cause a very strong inflammation reaction in the bowel that actually changes the cells lining the bowel that can make them actually precancerous. So we've learned a lot about this medication, and obviously there have been a lot of lawsuits, and most of those eye lawsuits, I believe, have been settled. I don't know if we have any lawsuits related to inflammatory bowel disease. I will tell you here in my office that every now and then I find a patient who is on Elmeron who's had colectomies. Harriet here on Facebook said I had colon dysplasia and had to have my colon removed. And Harriet, that was after using Elmeron, right? That's classic. That's what we see with these inflammatory bowel reactions. Danielle, thank you, honey. Okay. Now let's talk about bladder installations. So there are, in general, oh, Harriet says I'm telling her story. Oh, Harriet, honey, I'm so sorry. I'm so, in hindsight, I think a flaw in our FDA system and a flaw with drug development in general is that there's just simply not good tracking. Because we've known again from day one that there were patients who had stomach and bowel problems with Elmeron. The assumption was it was the capsule. We now know that that's not the case. But whose responsibility is it to monitor those side effects? And that is the ultimate question here for any medications here in the United States that are FDA approved. Whose responsibility is it to track these adverse events and side effects? And then more importantly, address them and try to make them feel better. Try to find a way of resolving whatever that adverse event is. So Harriet right here, she's the classic example of somebody who suffered very severe inflammatory bowel changes after using Elmeron to the point that she had to have her colon removed. And you're not alone, honey. You're not alone. Okay, now with bladder installations, let's look at the two most common bladder installation. The first one is DMSO. DMSO is FDA approved for the treatment of IC. It's fallen out of favor. It really has fallen out of favor, and it has for the last 10 or 15 years. The big issue with DMSO is that it can be quite painful when you have it done. I mean, I had 8 treatments of DMSO myself, and the first installation I had, I actually tried to drive home with it in my bladder. Huge mistake. Listen, the rule for anytime you get a bladder installation, you never, ever, ever get in your car and try to drive home. Never. You sit there and wait the 20 to 30 minutes that you need to hold it in your bladder, and then you drive home. I tried to drive home with DMSO in my bladder, and I got stuck in a traffic jam. And that was in my bladder for a good 90 minutes. And by the time I got home, I was kind of screaming. Ooh, Sherry, hold that thought, hon. Hold that thought. DMSO is also known for causing a garlic-like odor that emerges from your skin. Of course, the other issue with any bladder installation is that it's going to tweak your urethra. And so the way we avoid tweaking your urethra and irritating your urethra is by using something called a hydrophilic catheter. What does that mean? It's a water-loving catheter. It means it's coated with slippery stuff. So it's easy to put in there and it's easy to pull out. We don't really want to do those big red rubber catheters anymore, because they're not slippery and they're hard to pull out. They don't feel good. A slimy catheter slides in easily and it slides out easily. Okay. Sorry. Again, guys, you just know that I'm just dealing with these super, super annoying incisions. I coated them with lidocaine and something today, but right there, it's getting me. Stop it. Stop it. Oh, healing from surgery is so annoying. Okay, let's go to a rescue install. A rescue installation is, in fact, the most popular IC therapy out there for bladder installations because it can rescue you out of a flare. So a rescue installation has a combination of something like heparin, something that will coat your bladder, combined with lidocaine, something that will numb your bladder. But there can be variations. It can be chondroitin sulfate instead of heparin. Could be Elmeron instead of heparin. It could be Marcaine instead of lidocaine. Doctors love to create their own formulas. Sometimes they put a little steroid in there. Sometimes they put a little antibiotic in there. Anyway, the point of a rescue installation is to coat your bladder and temporarily, for the short term, turn the nerves off, so that hopefully you'll be walking out of that urology clinic pain-free. And hopefully your pain will stay off for several hours or maybe even a day or two before it wears off and you start feeling some symptoms again. Now, kind of the theory behind this is these sensitive nerves in the bladder are rather difficult to turn off. And so what we're doing is we're physically turning the nerve off consistently over time, one installation every week for like 8 weeks. And the goal here is to just keep it off, keep it off, keep it off to try to calm it down to the point that it can stay off on its own. I guess that's the best way to explain it. So what are so are there consistent side effects with the typical rescue instill? Yeah, there is. Usually it's a reaction to the lidocaine. If you have a rescue instill and you feel worse afterwards, that means that there's something in that installation that's provoking you. And so quite a few patients are sensitive to lidocaine. And so the next time they'll do it with Marcaine. And this is also where we have to rely on the knowledge and expertise of the person creating the installation. Because I can give you an example of, okay, this is a true story in a urology clinic back east. The doctor asked a staff member with no medical training to assemble an installation, like a receptionist. And so the staffer, wanting to do good, did what she thought was the right thing to do, but she didn't understand dosing. And she ended up making it so strong, it actually damaged the bladder of the person that they were using it on. And it all went back to the fact that a non-medical person was asked to assemble it. She didn't get the dilutions correct. So in other words, she used like a full strength instead of a partial strength in this installation. So if you, for example, have been getting installations regularly and you've never had a problem with it, and then all of a sudden one day you have a really bad reaction to it, okay, that's when we want to look at the medical record and see what happened. Because there's no reason, if you've tolerated it really, really well for months and months and months, and all of a sudden it has you crying in pain, we have to look and see what they did. Did they use a different ingredient? Did they use a different source? Did they have somebody else formulating it where they might have made a mistake? My co-leader, Evelyn, for my original IC support group, she did rescue installations. And that's exactly what happened to her. She did them. She was fine with them. And then one day she went in and she was just screaming with pain. And it turned out they used a salt solution rather than water as a base. And I don't know why, but she ended up having the equivalent of a salt burn. So again, if you've been doing rescues, fine, all of a sudden something happens, your immediate question back is, what's different? And they might hem and haw, go, oh, nothing's different, nothing different. You got to put your foot down. Say, guys, listen, I have had 8, 10 of these from you. This has never happened before. Clearly something is different. I want you to look at this. And let's see. And sometimes you even have to ask for your medical record. It's like, let me see the medical record. But errors happen. They can happen. Okay, let's go on now to antidepressants, because antidepressant medications are commonly given not because they believe that it's all in your head, it's because a low dose antidepressant helps to calm the entire nervous system down. And it is, in fact, the nervous system which is driving a lot of these symptoms. So the typical antidepressants that are prescribed to IC patients are going to be amitriptyline, also known as Elavil, or maybe imipramine, or maybe nortriptyline. Antidepressants are by far the hardest medications for patients to take over the long term. Why? Because they have the largest side effect. They have the most consistent side effects. So this is fatigue, dry mouth, dry eyes, weight gain. We call it the Elavil 20. There's something about it that makes you start snacking. And so when you're on amitriptyline, all of a sudden you're looking for snacks all over the place, and before you know it, you gain the 20. I gained 20 pounds when I did amitriptyline for 3 months back in 1993, believe it or not. And as soon as you stop the medication, the weight should go away. So it's important. Another thing that amitriptyline can do, amitriptyline can change the conductivity of your heart muscle. So it's very common for patients to struggle with tachycardia or PVCs or arrhythmias using a low dose antidepressant. If you're somebody you can't take ephedrine, you can't take allergy meds because it makes your heart race, then the odds are you're probably not going to be able to take these low dose antidepressants because they will do exactly the same thing. So what amitriptyline did to me is it changed my heart rhythm. I took it for 3 months. And I started getting all these really weird heart irregularities. Sometimes my heart would kind of stop and then it would triple beat, and it was just scary as hell. So I go back to my doctor. It's like, what the hell's going on with my heart? They go, oh, well, we need to stop the amitriptyline right away. And then I wore a heart monitor for a month, like that long, a month. And what they found is that the amitriptyline had activated a third node in my heart. So, your heartbeat is normally beep, 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 because that's the SA node and the AV node beating your heart to push blood along. It turned on a third node for me. So my heartbeat was beep, 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 beep. Freaky. Sometimes 2 nodes beat at the same time. So it'd be a beep, 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 beep. And that was scary. And it is now 30 years later, and my heart is still messed up from that. I still get arrhythmias. I still get tachycardia that I go all the way back to doing that amitriptyline. And so I can't do caffeine. I can't do medicines that have the ability to mess my heart up in that way. And in fact, I do take medicine to keep my heartbeat steady. I take a low pressor, and I feel good on that. But so that's an example of having, I think, a really, really major side effect that you should not be living with. If you start developing tachycardia, if you start developing any weird symptoms like that, you need to call your doctor immediately. I waited like 6 weeks. Big mistake on my part. And again, 30 years later, I'm dealing now with this. I still have a third node that occasionally decides it's going to beat every now and then. Very, very annoying. Now, last but not least, I think the biggest issue with a low-dose antidepressant is that these are called anticholinergic medications. Anticholinergic medications are now linked to dementia and cognitive decline. And these are very, very large research studies with over tens of thousands of patients who have been studied in the last 25 years. And so if you take a certain amount of anticholinergic medication every day for 3 years, that gives you a 50% increase in the risk of cognitive decline and dementia. And so we had warnings produced by the FDA several years ago, really encouraging doctors, especially if you're over a certain age, if the patient is over a certain age, to go back and look at all those meds they're taking and try to back off of the anticholinergic meds so that we're not creating the risk. So anticholinergic meds are going to be the antidepressants, but they're also going to be the overactive bladder meds, the ditropans, the detrol. So if you're taking an antidepressant and at the same time you're taking a medication to try to control frequency urgency, then you're significantly upping the risk of cognitive decline. In contrast, mirabegron, also known as Myrbetriq, is a medication that can help control frequency urgency. that is not an anticholinergic, that does not increase that risk. Understand too that there's some medications over the counter that add to that risk because they have anticholinergic properties, some allergy meds and things like that. So, as a support group leader, working with patients every day, and as a coach, as an IC coach, working with patients every day, I at least once or twice a week, somebody calls who is massively over medicated because you can hear it in their voice. They're dull, they're barely able to put a sentence together, they're very, very fatigued. Um, and when I start asking, what are you taking? And the list of anticholinergics gets longer and longer and longer. And that's what causes this diminishment of cognition. And so, what our American Urology Association guidelines say, and this is so incredibly important that you focus on this, is that if a medication is not making you better, it's important to stop it, take a step back, and revisit the diagnosis. That's what our national guidelines say. If the patient is not responding to treatment, stop what you're doing, take a step back, and revisit the diagnosis. And again, now that we have phenotyping, right? Now we have a better idea of which medications work for different people. So back in the old days, 10, 15, 20, 30, well, not 30 years ago, but up until 1996, everybody was given Elmeron and an antidepressant. And it didn't work. So what did they do? They increased the dose. It still didn't work. But now they end up with all these side effects. We had a brand new study that came out this month. And it was a study that very clearly said patients with local symptoms, like very clearly the bladder wall, like from estrogen atrophy or Hunner's lesions, those patients need local therapies. We have to give them a treatment in their bladder to fix what's going on in their bladder. But patients who have systemic symptoms, they've got the widespread pain, they've got the IBS, the vulvodynia, the TMJ, very sensitive skin, wicked sense of smell. That's not a local patient. That is a systemic patient. That is a patient who has a fundamental problem with their central nervous system. I'm in this group. And to give us local therapies is pointless because local therapies, bladder therapies, don't fix the underlying nerve problem. And that's what we have to be laser focused on, is calming the nervous system. So yesterday, I was very lucky. Dr. Robert Eckenberg and I hung out for a couple hours. I wasn't feeling that good. I was dealing with nausea and surgery, and and he was worried about me. It's like, Jill, you're working too hard. And it's like, I know. Jill, you have to rest. I know. Anyway, I was interviewing him because we're putting together a bunch of little mini videos. And kind of that's really the conclusion of what we were talking about yesterday. And I'll have these videos up on YouTube soon. If you keep chasing locals, okay, I got to say this better. If you keep chasing your symptoms, so think about the typical ICIBS migraine patient. So you're going to the doctor for the migraines, and you're taking migraines medicine. You're going to the gastroenterologist for your IBS, and you're taking IBS meds. You're going to the urologist for your IC, and you're taking bladder meds. And you can do that for years and still be struggling. Why? Because underlying all of those conditions is a central nervous system problem. That it's driven by an injured, traumatized central nervous system. And so therapeutically, for these patients, well, it's so tempting to want to just keep doing bladder therapies because your bladder's screaming at you, or bowel therapies because you always have diarrhea, or migraine therapy. And of course, logically, you're going, of course, I have to take these meds. But at the same time, you have to be laser focused on what's amplifying the pain everywhere. And what's amplifying the pain everywhere is an injured, traumatized central nervous system. This is the widespread pain subtype. This is 40% of the IC population have many pain conditions. I'm in this group. And I will tell you, I have a perfectly healthy bladder. There's nothing physically wrong with my bladder. And yet I was peeing every 30 minutes for years. Why? Because the nerves in my bladder had become very, very sensitive. Why? Well, two reasons. Number one, I broke my damn tailbone when I was 13. That didn't help. I had a really major injury down there. But I was also a victim of very serious childhood trauma. Very serious childhood trauma. And Dr. Eckenberg, in his book, and so this is his new book. It's called The Handbook on Treating Chronic Pelvic, Genital, and Sexual Pain Disorders. It's now available on his website. You can buy this now. But it's really kind of more for clinicians than it is for patients, but it's very useful for patients too. But what he is trying to do is he's trying to help doctors build a better pelvic pain clinic. That you can't just keep focusing on urology. You can't just keep focusing on gynecology. Underneath it all is pain science. It's completely and totally related to pain science. So anyway, in this book, and the way he explains it is, think about an electric guitar. How do you make an electric guitar louder? You either hit the string really hard, bang, or you plug it into an amplifier. When you plug it into an amplifier, you can turn up the volume and it'll get louder. And he said, your central nervous system is the amplifier. It's your central nervous system that, for many of us, is increasing pain. Okay, so in what context then does the central nervous system increase pain? Well, it's all about injury or trauma. So, back in the day, Donna says, if we could learn to control our nervous system, my God, what would our lives be like? Wow, yeah. So back in the day when I was younger, the old timers would be sitting out on their front porch, talking to each other, smoking a pipe, drinking coffee, whatever, or drinking their beer. And eventually one of them would start rubbing their knee and they go, oh, storm must be coming in. My knee hurts. Okay. And it turns out a storm really does come in. Okay. So why does his knee hurt? His knee hurts because at one point in time he injured that knee. He might have broken that knee. So you can have a broken bone. You can have a ruptured muscle. But you also end up with injured nerves. The problem is that while the bone heals and the muscle heals, what does an injured nerve do? An injured nerve becomes a sensitive nerve. It's physically easier to turn on. And so when that air pressure changes, that nerve starts to give some discomfort. Even though everything else is long healed, that nerve sensitivity remains. And so what Dr. Eckenberg says here is that generally it's a series of little traumas over time. It can be from falling down the stairs. It can be from having a baby. But for a lot of us, it's due to athletics. Guys, I was just a really good athlete when I was in high school and college. And I loved working out. I toured. I did a tennis tour. I played on teams. I did a lot of tournaments. And fell in love with running up and down stairs, running upstairs. Like I ran up Diamond Head in Hawaii. I loved running up things. Didn't like coming down, loved running up. I loved the Stairmaster. My workout was 100 flights of stairs a day. And I did, and that was, then I would swim a mile or two, and then I'd go row 5 miles. That was my typical workout. I loved that workout. I had no clue the damage I was doing. No clue how much I was hurting my body over time. And so Dr. Ackenberg says, we see this in athletes. You know, you love to run. It's how you manage your stress. But the wear and tear of running on concrete, it's going to take a toll on the entire body. And it causes injuries, it causes trauma. And so we see minor traumas over time that slowly but steadily amp the nervous system up. Now, you have no idea until finally one little random thing brings it over the top, and now we've got a nervous system that is triggering pain. Might be something really simple like stumbling. So he demonstrated it in my talk with him yesterday, that the pain, the sensitivity builds and builds and builds and builds and builds and builds. And then there's one random event that brings it up over the top where you, the patient, now feel it. And then the more trauma that happens, the more intense the pain gets. So this is not all in your head. This isn't even close to being all in your head. This is about physiological changes in the nervous system. That we have injury, we have trauma. And as this nervous system becomes more sensitive, we get bladder sensitivity. So for those of you, they go in, they look at your bladder, you have a normal bladder like I do. Okay, you clearly don't have a bladder disease because you have a normal bladder. There's no disease process happening. So what's driving the frequency urgency? Sensitive nerves. I will say that I was the standard, perfect patient fitting the widespread pain group. I had all the conditions throughout most of my 20s, and then the bladder pelvic pain started when I was 32. And my life was not normal. I needed it to be normal. It wasn't. My friends were out getting married and having babies. I was laying in the fetal position in my bathroom almost every morning with terrible spasm. All of those symptoms are gone now. Why? Because I learned how to calm my nervous system down. And I also got my head straight, because up to that point, I really thought I was damaged goods and it was my fault. When I finally learned, oh, this is what happens after trauma. Oh, well, I certainly had a lot of trauma. That makes total sense. Knowledge is power here. Knowledge is really, really power here. So again, getting back to what we're talking about here. For that patient with estrogen atrophy, are taking antidepressants which calm the nervous system down viable? And the answer is probably no. Number one, their symptoms are being driven by a thinner bladder wall. So the correct therapy is going to be something that contains estrogen to help boost the production of mucus, combined with something that will coat the bladder. And most importantly, we don't want those older women taking an antidepressant, which is going to risk their cognitive decline. And I'm going to say right now here, guys, there was one study that tracked cognitive decline in patients in their 20s. And cognitive decline occurred in patients in their 20s who were using antidepressants. So, you know, and yet on the other hand, depression is a real thing. I think that the point here is that short-term or long-term use creates more risks. And, you know, I'll be real honest here. I have been struggling with a little bit of depression. I have been. It's been a rough year for me. Very, very rough year for me. I am unwilling to take an antidepressant because I know my heart won't take it. My heart won't tolerate it. So it's my responsibility to make sure that I'm doing other things that will bring me calm and peace and comfort and get me through what has been a pretty rough patch. Okay, let's go then to antihistamines. So, antihistamines are commonly prescribed for IC patients, especially if you have a history of allergies. Very, very well known that some patients flare during allergy season. Why? Because that allergenic effect doesn't just affect the sinuses, it can affect other parts of the body. And there are some patients who suffer with bladder flares during allergy season. And so these are the patients that we're going to target with a low dose antihistamine like hydroxyzine. Hydroxyzine, um, I think hydroxyzine is really, really interesting because number one, it has a beneficial side effect. And that beneficial side effect is it calms anxiety. I'm like, oh man, I'm all for that. Helping us get control of anxiety is a good thing. When I took hydroxyzine for about 8 years, um, and I finally stopped it when I started developing night terrors. So we call them hydroxyzine dreams. That when you're taking hydroxyzine, which is known as Atarax or Visceral, it changes the way your brain dreams for some patients. So a happy dream becomes an incredibly joyful dream. A sex dream becomes a, oh my God, best sex of your life ever with your favorite Hollywood actor dream. I actually had a dream like that. And then a nightmare becomes a night terror. And I finally, after 8 years, started having night terrors where literally my dream was watching my family's necks being slashed, I mean, really, or my cat being killed in front of me. But I knew exactly what it was. It was a night terror from the med. And as soon as I stopped the medication, it went away. I haven't had any since. So if you're taking hydroxyzine and your dreams are changing, that's classic with that med. And once you hit that point where it's causing night terrors, that might not be the medication for you. Hydroxyzine also is sedating. And so generally we don't take it during the day. We take it at dinner time the night before so that there's enough in your bloodstream by like 10 o'clock so that it will help you sleep. But there's not so much in there that you will have a difficult time waking up the next morning. I found with hydroxyzine that it was like an extra layer of sleep. It was just harder to wake up. You had to push through one more layer of sleep to actually wake up. But once you're up, you're fine, no drowsiness. But if you take it during the day, you're going to be drowsy, and that just sucks. We have to function during the day. Most importantly, hydroxyzine is an anticholinergic medication. And so again, we want to make sure we're keeping our anticholinergics slim to none because we want to protect our brains. Antispasmodic medication. So we've got a couple of different types of antispasmodic medication. We've got smooth muscle relaxants that are designed to calm bladder spasms. That's going to be the ditropans and detrols. Those are very strong anticholinergic meds. Those all now have warnings in there about dementia and cognitive decline. So the place where they kind of work is if you're struggling with bladder spasms. And so, for example, I went through a period where it turned out I had a bladder infection that I thought was a flare. And so for 6 weeks, I was dealing with this flare that was getting worse and worse and worse and worse. And then finally it got to the point where I dreaded going to the bathroom because I knew as the last couple of drops were coming out of my urethra, I would be bent over in this violent bladder spasm. And I showed up at my urology clinic sobbing, and they'd never seen me sobbing because I ran their support group. They saw me crying and like literally grabbed my arm and pulled me in. I didn't have to wait. They like brought me right into the nurse's office. What's wrong, Jill? And I described the symptom. It's like when I try to urinate, at the last couple of drops come out, I'm like bent over. The pain is so severe, it shoots up my back. And the nurse goes, Jill, don't you know what that is? And I'm like, no, I don't. I've never had this before. And she goes, that's a bladder spasm, honey. That's a bladder spasm. And they tested my urine. It turned out I had a massive infection. And she gave me oxybutynin, also known as ditropan. And it turned it off in 20 minutes. 20 minutes. And so, with these types of medications, the challenge with taking something like oxybutynin, ditropan, is that it slowly deadens the nerves that help you urinate. And so after 6 weeks, 4 weeks, 6 weeks, you're going to sit on the toilet and you're going to have to push because it's like the nerves have gone to sleep. And that's from the medication. In fact, I was just working with a patient who that happened to them. And when they did a sonogram of her bladder was still filled with fluid because she had just taken the medication too long. So I tend to think of the bladder antispasmodics as ideal for use if you're having bladder spasms for a very short period of time. But they're not necessarily ideal for long-term use. Again, that's the anticholinergic ditropans or Detrol. Now, we also have the new one. We've got Mirbitric, which is not an anticholinergic. That might be more viable for the long term. But the ditropans and Detrols, it gets harder and harder to pee over time. And when you're an IC patient, you want to pee. You want to get it out of your bladder because you will feel better. Now, there's another type of antispasmodic called a skeletal muscle antispasmodic. This is what we do when the pelvic floor muscles are spasming, because these are different types of muscles. You got the smooth muscle of the bladder versus the skeletal muscle of the pelvic floor. Skeletal muscle is muscle that your body uses to move itself. It's essential to movement. So the pelvic floor muscles help you open and close your legs and walk, etc. So this is skeletal muscle. So for these patients, if you have very, very tight pelvic floor muscles, they might prescribe you something like baclofen. Baclofen is a non-sedating skeletal muscle relaxant. So you can take it during the day, not going to interfere with your ability to drive or work. So baclofen is a very popular skeletal muscle relaxant. I couldn't take it. It made my face itch. I tried it twice. Both times it made my face itch. I don't understand why. So I took Flexeril, also known as cyclobenzaprine. In fact, I took it last night. Very, very tiny dose. So when I feel my muscles getting really, really tight and I'm struggling to relax them, or they're very, very tender to touch, then I will throw in a skeletal muscle relaxant. But again, the biggest side effect for these meds is that they're sedating and you can't drive with them. So when I take it at night, and then the next morning I'm usually fine and much better. Let's now go to Botox. So Botox is a medication that a lot of patients just don't really understand. The doctor says, hey, let's just try some Botox. What the heck? Well, Botox is a deactivated tuberculin bacteria. And it turns out it turns nerves off. And so Botox has been used for a lot of things. They do it, cosmetically on your face to get you to stop raising and lowering your eyebrows like that. Obviously, I've never had it. Botox has been used in the jaw for TMJ. It's been used with migraines if there's a very tight muscle that's triggering those migraines. Botox, if injected into the bladder wall, can silence the nerves of the bladder wall that might be causing frequency and urgency. The biggest risk of Botox, though, is that it will silence every nerve it touches. And if it touches the nerves that control your ability to urinate, guess what? You're not going to be able to pee. You're not going to be able to pee. And this just happened to a patient last week where at first it seemed okay. And then the next day she couldn't pee for a good 15, 16 hours and is now facing the need to self-catheterize. And so if you look at the FDA approval for Botox, the FDA approval says this should not be done in people who are unable to self-catheterize. You know, your nerves in your bladder wall are like a little spider web. I mean, yes, they generally follow certain pathways, but they can deviate to the left, to the right. And so when they're injecting the bladder wall with Botox, they can hit that nerve which controls your ability to pee, and you might need to self-catheterize. So that's important. And that same person is having a lot of pain now in her bladder because she cannot empty her bladder. So you have to approach Botox carefully and understand that there are really significant risks. Pelvic floor physical therapy. So what are the common side effects of pelvic floor physical therapy? Well, what gets very, very confusing to patients, now remember, we now believe that 85% of IC patients have tight pelvic floor muscles. So we have to work with those muscles. We don't want tight muscles. Tight muscles are bad. They start restricting blood supply to the bladder. They start restricting blood supply to the nerves. They start squeezing nerves. This is not good. This is bad. We have to get normal muscle tone in there. What confuses a lot of patients is when they go to pelvic floor physical therapy for the first time and they're getting their pelvic floor assessment, it hurts. You know, remember the pelvic floor assessment, they're doing here, hold on a second. So let us talk about the pelvis here for a moment. So here's your pelvic floor. So here's your hips. This is from the front. And when we look down from the top, we can see the pelvic floor muscles. And the pelvic floor muscles are shallow. Hi, Kayleen. They sit along the inside surface of bones. Okay, so when you go to pelvic floor physical therapy, especially for that first appointment, they're going to ask if they can do an internal exam. Please do it. It's the single most important part of that exam because what they're going to do is they're just going to touch muscle groups. They're going to touch shallow muscles. They're going to touch deeper muscles. And if they can touch a muscle and trigger your pain, that is what I call your hallelujah moment. That's very exciting because they found it. And your immediate question is, oh my God, that's it. What are you touching? And hopefully they'll say, oh, that's your obturator. That's your piriformis muscle. That's your levator ani muscle. Especially if you have pain that's on one side. Because remember, the bladder is centered. So if you pain on one side, then that's probably going to be pelvic floor driven pain. But again, some patients are not prepared for that. And so when they have physical therapy and when they go in and they work with those muscles and they have pain afterwards, the patient is like, oh, I'm not doing that again. Oh, hell no, that hurt too much. And I was working with a patient on Friday who said, no, it hurt too much. And I went, no, that's a good sign. If they touched a muscle and it hurt, that's fantastic because now we know we're working in exactly the right area. And so now we know that the physical therapist just has to go a little slower and be a little bit more gentle. And so, you know, I personally have never found pelvic floor physical therapy painful as they're doing it. And they always are watching your face. They're looking at your face to see if you wince. I'm one of those people that I giggle. I just laugh. When they do something, I just spontaneously laugh if it gets weird and uncomfortable. But I have never found pelvic floor physical therapy to be difficult. I can't even feel it until I start walking out to my car. When I walk out to my car, then I go, "Oh, yeah, we were working down there. We were working down there." And then when I would actually go from standing to sitting in my car seat, that's when it's like, "Okay, yeah, that's actually uncomfortable." When I had pelvic floor therapy after my hysterectomy, yeah, I cried a couple of times, but I knew to go back. I knew I had to go back, and by the 3rd physical therapy appointment, the pain was massively better. So don't be afraid of pain during a physical therapy. That's actually tells us we're working in the right area. Just means your physical therapist has to back off. Now, last but not least, we need to talk about neuromodulation and side effects and adverse events that are associated with neuromodulation. So remember, when I began this discussion, we're talking about what are when is it time to cry uncle if you're having a side effect? If a treatment, if a medication is interfering with your quality of life, if it is making it difficult for you to function, if it is making you worse rather than better, it's very important that you stop what you're doing. I mean, you talk to your doctor, make an appointment, and say, "Hey, listen, doc, this is not working for me. I am really struggling. I would like to explore other treatments." Don't stop medications without talking with your doctor first, though. I mean, send them a message. Make sure, because there are some medications like Cymbalta, you can't just stop cold turkey. You can get something called a discontinuation syndrome. So you got to have a good discussion with your doctor, and you got to do your research and read about stuff too to make sure you understand what the challenges, if any, that might be with that med. Like the hydroxyzine, super easy to stop, doesn't cause dependence at all. Okay, so let's go back to neuromodulation. So neuromodulation also has been pitched extensively to IC and overactive bladder patients. The theory behind it is that we've got dysfunctional nerves. So if we give the nerves a nice gentle impulse, it will normalize nerve function. It is FDA approved for the treatment of incontinence, frequency, urgency. It is not approved for IC. It is not approved for pain control. And yet there are quite a few people out there who are saying, yeah, but it might work, so why not give it a try? Well, here's the problem. Surgical neuromodulation comes with substantial risks. InterStim has hundreds, thousands of adverse events reported to the FDA. The patients have gone through injuries, traumas. There's a lot of postoperative MRSA infections at the site of the surgery. There are a lot of device failures, a lot of devices moving. There are actually also fatalities. The last time I counted, there were about 20 fatalities associated with the use of InterStim. And the problem with our FDA reporting system is that they never explain it. What we have is a doctor or a patient or a family member reporting that this patient has died, and yes, they had InterStim. So was it related to the InterStim? We never find out. However, the last year when I looked, the last fatality was like last December, about a year ago, and it was of a patient who had InterStim, whose doctor had either retired or moved on. Then the patient developed an infection around the site of the surgery that they did. And so the patient ended up at the emergency room, and the emergency room staff and the hospital staff could clearly see that there was a sizable infection going on. But they had to reach out to the company to try to figure out what to do about the infection, because there was no doctor who had experience in it. And the patient did die of that infection. And so the way you can look at adverse events filed against patients, filed reporting problems that patients have experienced with certain medical devices, is with what we call the MAUDE database, MAUDE, like the old TV show. Of course, a lot of you are too young, you don't remember the MAUDE TV show, but us old timers do. MAUDE. You can just Google MAUD database. Type in, go to the search page, type in InterStim, adjust the dates, and there are just it's very, very important, in my opinion, if you're considering surgical neuromodulation, that you go through those adverse events so your eyes are wide open about what the potential risks are. It's expensive. It may require multiple surgeries. If you lose your health insurance and you need surgery, guess what? You're going to have to pay for it out of pocket, and that could be tens of thousands of dollars. One of the questions that I think it's really important to ask your surgeon if you're considering having neuromodulation is, will you cover me if I lose my health insurance? Who would I go to if I lose my health insurance? Because whenever you have a device implanted into you, whether it's a pacemaker, a defibrillator, or whether it's an InterStim or some sort of other device, it has to be monitored and checked regularly. You don't just go on your way, because it can malfunction, and at the same time, you might have to turn it off. You might have to turn it on. It can move. All sorts of things happen. So it's very, very important, if you have sacral neuromodulation, that you have a doctor that will work with you consistently, and you're going to be going into that doctor's 2 or 3 times a year to get it checked. But what happens if you lose your health insurance? Guess what? Those patients can get dumped. And now you've got a device that's malfunctioning, and you're getting shocked every time you have a bowel movement. But you don't have the health insurance anymore, and that doctor refuses to see you. This is a true story. This happened to a patient. She called me. She didn't know what to do. She was getting shocked all day. And we ended up calling company, because ultimately it's a company's responsibility to make sure that there are doctors trained in it. So we called the company, reported what happened, and said, you need to find her a doctor. And it turned out in the state of in Florida, there was only one urologist who would see her, because she had lost her job, she had lost her health insurance, and she was on Medicaid. So I am not a fan of neuromodulation. I think it's too expensive, and I think there are far too many risks. And I think that the context where sacral neuromodulation can be spectacularly successful is with patients who have fecal incontinence or urinary incontinence. It has a chance of completely turning the incontinence off, and that's proven in research, and that's why it was FDA approved. And so if you have extreme incontinence, and I say power to you, go for it. You just got to have your eyes wide open. Okay. But if a doctor says, hey, that might help with your pain, hopefully you've come over to our website, you've read our section on it, which says not approved for pain. The FDA specifically says that, and it says that patients should be advised that this is not known for turning pain off, and yet you have a doctor who says, it might, give it a shot. You got to ask yourself, is it worth the risk? Is it worth the risk? So to sum this up, this is all about you understanding that there are risks versus benefits associated with treatment. There are risks versus benefits associated with medication. And if you have an adverse event, that doesn't mean you have to live with it. I'm not going to live with nausea every day. It was rough. Like today, it's the first day in 6 weeks where I am not that nauseated. I'm not nauseated. Why? Because of a medication they gave me. And for those of you who have widespread pain, you're already really sensitive. We're already really, really sensitive. So finding meds that work for us can be very, very challenging. Anyway, well, that's my shtick for today, is talking about adverse events and reminding you that if you're struggling with side effects, call your doctor. Let them know. There might be something else you can do besides that. You deserve to have a comfortable, happy, joyful life. All right, so let us take questions now. Okay. So Patricia here on Fit. So you guys, we're live streaming. We're streaming on YouTube. So if I'm looking over here, I'm looking at YouTube. If I'm looking here, I am looking at Facebook. So let's go to Facebook first. Actually, no, let's go to YouTube first. Francis says, thank you, Jill, for the deep dive into meds and side effects. Very eye-opening for me. I've had bladder issue all my life, but pregnancy at 35 and second C-section at 40. Oh, honey, I'm glad that we could help. And so to me, the most important question here is, what's your phenotype? When we figure out what your phenotype is, then we might understand why your symptoms have been persistent. And are you better today than you were before you had children, or are you worse? Those are really important. Danielle says, my urologist keeps trying to get me to do InterStim again after the first failed trial. Says it helps with the pain. Well, okay, now maybe I'm out of touch. Hold on. Let's check. Is InterStim FDA approved for pelvic pain? No, it is not FDA approved for the treatment of chronic pelvic pain. It is approved for conditions like overactive bladder and incontinence. The FDA has not cleared it for treating pelvic pain alone. And if we hold on a sec. I wanted to give you the exact language. Medtronic did get FDA approval for a new battery system that will provide a battery for 10 to 15 years rather than 2 to 3 years, where patients will not have to recharge it. So that's kind of cool. Is that the FDA approval? Here we go. Here's the actual FDA approval. April 15th, 1999. I want to see. So it's specifically approved for the treatment of urgent incontinence, urinary retention, and significant symptoms of frequency or urgency in patients who have failed or could not tolerate more conservative treatments. I know that they had a section on pain. I'm remembering reading that years ago. Potential adverse effects. Lead migration, 11%. Technical problems, 2%. New pain, 2%. Device problems, 1%. Persistent skin irritation, 1%. Changes in bowel function, 0.5%. Infection at the stimulation lead site, they say it's 0.3, but man, there's a lot more. 33% revisions, 15% pain at the IPG site, 9% patients experience new pain. Yeah. Doesn't make any sense to me. I mean, and if you're interested in exploring neuromodulation, then you can try the ankle stim first. Urgent PC. That's the exact same FDA approval for frequency, urgency, and incontinence, but it doesn't involve surgery at all. They just use an acupuncture needle at the ankle, and they basically attach a TENS unit to it, and they stimulate the same nerve group just where it's closer to the surface of the skin. So if you wanted to try neuromodulation first, go with the ankle stim. It doesn't require surgery. There are very, very few risks. There are very, very few filings with the FDA. Usually just for numbness in the skin area, in contrast to these thousands of reports of infections and lead migrations and all that sort of stuff. And Danielle had a trial and it didn't help. So if it didn't help, it didn't help. Time to move on. Now we got to figure out why you're in pain. You need to be phenotyped. You need to be phenotyped correctly. We need to understand what's driving that pain. If you have widespread pain, you got multiple pain conditions, the IC, the IBS, the vulvodynia. If you got sensitive skin, if you've got a wicked sense of smell, your central nervous system is driving that pain. So we have to do therapies that target the central nervous system, things that will calm the central nervous system down. And this is about and I've talked about that before. Remember, the central nervous system gets amped up and starts to amplify the pain after trauma, after abuse, after bullying. And so, what we have to do is what we call mind body medicine techniques that will physically calm down the fight or flight response in the brain. Patients who have widespread pain are stuck in fight or flight 24 hours a day. Pain that is accompanied by anxiety is intensified by the brain. Pain accompanied by laughter is minimized by the brain. So, Danielle, I'm going to guess you have anxiety disorder. I do. I did. It's very, very controlled now. So you should give me a phone call next week, and let's see if we can phenotype you a little bit more accurately, because there's always a chance that it could be from your pelvic floor. And if it's coming from a tight, irritated pelvic floor, again, neuromodulation is pointless. We have to do the physical therapy, the hands-on physical therapy to get these muscles healthy. You just have to remember that, oh God, what was I reading? Who was that? I was talking to a doctor and we were talking about the motivation for surgery. And the doctor shocked me and said, Jill, you have to understand that number one, there are like two critical points. Always remember that urologists are attracted to the field because they're really good surgeons. They're surgeons. So urologists like to do surgery. They've gone into the field because they're very good at surgery. And so when you come in presenting with a chronic condition like IC, you're a disappointment because they can't necessarily operate on you, and they like to be in the OR. So InterStim is an opportunity for them to be in the OR. The other thing that this doctor said to me, I've never had a practicing doctor specializing in IC say to me, you have to understand, Jill, that surgery is a moneymaker. And health insurance companies and HMOs are trying to make money. And so it's not at all unusual for doctors to suggest a surgical fix if it will bring in more money. And that shocked me. It shocked me. Because I hate to think that our medical care is being driven by profit. And then it makes me go, okay, when the doctor told me I needed a hysterectomy because I had endometrial hyperplasia, okay, was that motivated by wanting to make a quick buck, or was that trying to save my life? And I love that doctor, my old OBGYN, and he did believe that I had tumors in my uterus, which I did not. I had earliest signs of cells that might have been changing into cancer, but they were not growing tumors yet. And then having breast cancer. Now, that was the easy one. I absolutely had breast cancer in my left breast. Now, it would have been in their best interest to maybe go the lumpectomy. If we're being really, really jaded here, we could argue that maybe they would suggest a lumpectomy, knowing that they often don't work, and that would be a second surgery, maybe more, and then eventually could lead to a double mastectomy or a single mastectomy. And then, I mean, that's really out there. I don't believe that at all. But, in my case, it was like, okay, it's there. I've had 2 biopsies. You found it. Take them all. Just take them. Be done with it. And that was my choice. That was my choice. And I'm living with that choice. And I'm happy with that choice. I'm not happy with the recovery, but I'm happy with the choice. So, anyway, Fireflower goes, wow. I know. I did a wow moment when they said that to me. I could say more, but I don't want to get sued. I could talk specifically about a treatment that's promoted in IC, but I don't want to get sued. So I'm not going to say more. Just learn before you say yes, learn about it. You got to learn about it. Okay, let's go here to Facebook here. Renee said, easy to throw out the SI joint. Yep, it is. Renee says, don't laugh, everyone, but I listen to Elvis gospel at night to go to sleep. It helps his tension and turning it off. Renee, that's something that, like, I right now am listening to the Chronicles of Narnia at night. Like, I literally just turn on a book, and I usually can't even remember the first minute. I'm usually down. But if I accidentally leave my iPad on like videos on YouTube, I don't sleep as well because there's too much stimulation coming through it, going from video to video. And I don't like listening to music at night, which is so weird. I need voices talking. It's strange. By the way, have you guys been following, like on YouTube now, there are incredible channels operating or offering all sorts of different music. So like in the fall, there's just this beautiful ambiance music, whether it is a little bit of jazz, a little bit of Celtic, a little bit of this, a little bit of that, and we'll have a beautiful picture of like a cat purring with its chest going up and down. So you're hearing the purr, you're hearing the music. I'm really enjoying exploring those, especially during the workday. I want to find, like, I don't like being in a quiet office. I don't like being in a quiet home. I always want something that is lifting me up in a way. Interesting. So check out the music channels on YouTube. I love them. Renee says, you're in great shape, not overweight. I understand I had to take osteoporosis med from a bone scan. Absolutely messed me up. You went off. I don't blame you. Yeah. Sherry said she didn't have any problems with the medication I had the problem with. I know, it's weird. I mean, but see, I'm prone to GERD and I have gastroparesis anyway. And the number one side effect of anybody taking Pradaxa for blood clots is stomach upset. Harriet said, the doctors negated the Elmeron was the cause. I showed my surgeon the study on the IC network. Yes. Yes, yes, yes. Sherry says, I have breast cancer, but had a clear margin, but something was in your bone density. You're on heparin and you don't have problems with it. Good. Harriet says, sodium bicarbonate irritated you? That's very rare, honey. Sodium bicarbonate's actually, when if you dissolve it in water, it becomes slightly alkaline. And so putting sodium bicarbonate, baking soda in a warm bath water feels wonderful. Using that little bit of sodium bicarbonate in a rescue installation actually makes that rescue installation kind of more comfortable. But we're all different. Harriet says, meds scare me. Yeah, me too. I have issues. Carol, hold that thought here real quick. Mary said, if you have bad frequency, I just read that is an indicator it's not your pelvic floor. Well, frequency is controlled by the alpha afferent nerve in the bladder wall. So the question then becomes, why is the alpha afferent nerve so irritated? That's what we have to figure out. The alpha afferent nerve can be triggered through a chemical stimulant. The alpha afferent nerve can be stimulated because you have a lot of neuroinflammation from tight muscles. And the alpha afferent nerve can be far more sensitive because you have the central nervous system increasing the sensitivity of that nerve, making it trigger more easily. Kayleen says, I know I'm going to cry tomorrow in physical therapy. She'll work on my gluteal muscles because of these pinched nerves. Yeah. Mary said, why do they keep telling people that they have no infection? Because when they keep having recurring infections or can't come off of antibiotics, I don't get why they can't put two and two together and why every urologist. Well, so Mary, the reason why doctors have to be a lot more cautious in prescribing antibiotics is because we now know that the more antibiotics you take, the greater the risk of developing resistances to it. So think about your biome for a moment. So our body, you're alive because you've got good bacteria in your body doing important tasks. We have as many bacteria in our body as we have cells in our body. We are an organism in which there are a lot of things happening. We've got bacteria that help us to just digest food. We've got bacteria that produces food for the cells lining your gut. We've got healthy bacteria on our skin. We've got healthy bacteria in our mouth. We need bacteria to live. And urine is not sterile. There's also good bacteria that live in your urine. So that's something that we've only learned in the last 15 years or so, that there's a lot of bacteria that are supposed to be in your bladder. The problem is when you take an antibiotic, it's like taking a flamethrower to a forest. It kills everything. It kills the good bacteria and it kills the bad bacteria. But it won't kill bacteria that have learned how to defend itself against it. So, for example, let's give a really easy example. Let's say you've got 10 different bacteria in your urine. And you take an antibiotic and it kills 9 out of the 10. But the reason why it didn't kill the 10th one is it had already learned how to defend itself. So the antibiotic could not kill it. So now with all the other good bacteria and bad bacteria gone, now we've got this one that grows and expands and dominates. And so now we've got a bad bacteria that is eating the food that the good bacteria need to survive. So then you do your probiotics, you take your acidophilus, and now we're introducing bacteria back into the bladder biome. But the challenge here is that this resistant bacteria now has a very strong foothold, and it's eating the food that the new bacteria need, so they starve. Bacteria are not stupid. At any given moment, they're all learning their environment and they're adapting to their environment and they're becoming resistant to threats. One of the things that E. coli does is an example. When an E. coli senses a threat in the form of a white blood cell, it changes shape. It goes from being round to being a noodle. It looks like a noodle. And when it's in its noodle shape, the white blood cell can't find it. It doesn't recognize it as a threat. That research was done by Scott Holtgren, who runs a fantastic bacteria lab studying E. coli. I think he's at the University of Iowa. Well, anyway, he's easy to find. So another thing that E. coli does when it senses a threat is it kills itself. but it creates little tiny seeds, bacteria seeds. So it will break apart and it's got little tiny pieces of DNA or RNA. It wraps them with a little protective layer and it plants them in the tissue. And so now we've got seeds. The question is, what turns the seeds on? Well, actually, the seeds get turned on when the body starts to heal. And so now we've got now we've got yet another infection going on. We've got these seeds that have now activated. So when you start messing with the biome with a lot of antibiotics, you're creating chaos. And the challenge here is listen, there's no population that's been more exposed to antibiotics than the IC patient. Because we all thought it was infection. Our doctors all thought it was infection. We've all taken massive antibiotics. I can still remember I was required to swallow 16 sulfas the first time I had symptoms. They thought I had a massive infection and they just fed them to me. So anyway, we got to be super, super careful with antibiotics. More is not better. It messes everything up. Ursula says, I've been getting dry needling and pelvic floor physical therapy for about 3 months, once a week. She's certified and I get dry needling in the glutes. I'm also doing physical therapy for a recent knee issue. My worry is I've been having back pain in upper and lower too. It's making, here, hold on. Making me worried because it's not going away. Could the pain have anything to do with the physical therapy? I'll talk to the physical therapist about it, but I'm getting up to pee a lot always. And now I have back pain. I'm having physical therapy in about a week. I'm an active person and work out fairly routinely, but I feel like I'm falling apart. Girl, you're not alone. I feel that way too. I mean, you just have to understand that for a lot of pelvic floor patients, they have symptoms that have been going on for years based upon dysfunctions and injuries that happened years ago. And so as we're now, as an example, let's look at somebody who's suffered a broken leg in childhood. Whenever you break the leg gets shorter. So now they've got one leg that's a half an inch shorter than the other. So what does that do? That tips their pelvis. So when they're walking with a tipped pelvis, which puts strain on the pelvic floor. Okay, but now we have, but your body adapts to it. Your body learns how to work with that. You know, there's all these little micro adjustments that your body will make to compensate for this slight discrepancy. But now you've gone to a physical therapist or a doctor who goes, oh, look at that. You've got one leg shorter than the other. And they give you a lift in one shoe just to get your hips level again. So you're thinking you're good, right? Well, yeah, we've got good biodynamics going on here. We know we've got our hips level, but now we have to deal with the fact that your muscles are used to being like this. And so there's going to be an adjustment period to get your muscles back to being like this. So it's not at all surprising that you might have a little bit of pain. Sorry, I got this thing, right there. Ow. It's related to my incision. So this is what we do. We rub these muscles. Stop it. Just stop it. Anyway, so we have to work with these muscles. They say it takes about a year to recover. Okay, I'm at month 4. You're going to see me doing this probably for another couple months. Hi, Nancy. Mary says, interesting explanation on antibiotics, but what are you supposed to do if you have too much bad bacteria and are very symptomatic. I can't get off the antibiotics or I get very bad. Well, so Mary, there's going to be a new UTI vaccines coming out that are going to be very, very. I mean, the potential for them helping others is just millions of people is just undeniable and spectacular. So I can't wait for the UTI vaccine to come out. We had one of our clients actually flew to London to get the vaccine because she suffered with recurring infections. In your case, you also have to, if you legitimately have infections over and over again, we need to figure out why. And for many women, the reason why they get recurring infections is because of their age, they're postmenopausal. So think about your bladder for a moment. It's the only organ in the human body designed to hold toxic waste. How does it protect itself? While it's holding ammonia and urea. It protects itself with a really thick coating of mucus. We call that the gag layer. And it's this thick coating of mucus that acts as a barrier that prevents urine from reaching the nerves in the tissue underneath. But it also prevents bacteria from reaching the bladder wall to infect the bladder wall. Okay, so this nice thick coating of mucus, the glycosaminoglycan layer, the gag layer, is critical to bladder health. Unfortunately, it is also estrogen dependent. So when you're young and have a lot of estrogen, you have a lot of mucus. But when you're older and you have less estrogen, or if you're on Lupron to suppress estrogen, you have less mucus, which means your bladder's ability to defend itself is compromised, which means that there are some women who they have so little mucus, the bacteria just swim right up to the cell and they infect the cell. We call this the genitourinary syndrome of menopause. And so therapeutically, the underlying reason why these women are getting infections is because their skin is in bad shape because it's dry. And so we want to make sure these patients are using topical estrogen, because when you give that skin estrogen, that skin starts to produce more mucus, which then will make it harder for bacteria to infect the cell. Give me one sec, guys. I need to go pee. I'll be right back. Pee break. I have returned. Ah. This is the side where they took lymph nodes, so this is the side that's more sensitive. Kim says, okay, here, hold on a sec. Actually, let's go to YouTube. Hello, YouTube. You guys are being so good to me. You're just hanging out. Thank you. Because, we're in this together, guys. We are in this battle together. My goal with these meetings is to give you comfort, give you hope, help you feel like you're not alone. This is not your fault. You haven't done anything wrong. You're just hurt, You're just hurt. Now, we're long past the days of giving patients Elmeron, giving them an antidepressant, and sending them on their way with a diet. We don't do that anymore. We know that doesn't work. We have to focus instead on trying to figure out the underlying cause of your symptoms. All right, so hold on a sec. Diane says, I've had 2 specialists, a urologist and a urogynecologist, recommend InterStim. I did PTNS this summer for 12 weeks and had now on monthly treatments. It helped for 4 days after. Okay, that's interesting. She says, having the treatment and then stopping till I have another treatment, so now being on monthly treatments doesn't provide as much relief of the frequency. Wouldn't constant neuromodulation help? It might. It might. I mean, we know it works for you. I mean, we know that your body responds to it well. I mean, I was one of the very first ankle stim patients back in 1993 when it was developed. You just have to have your eyes wide open on the risks of having it installed permanently. There are a lot of potential side effects with it. Carol says, I have Hunner's lesions and my surgeon refuses to write pain meds for my steroid injection surgery this week. He said my pain management doctor has to, but he won't refill it early. Do I know of a doctor at a place of excellence that treats Hunner's lesions? I'm having a hard time finding a good doctor in Oklahoma. The last doctor treated me awful. You always do universities. So like the university, I'm sorry, my hair's being all weird. The University of Oklahoma under Dr. Daniel Culkin was an IC research center for many years. I think he's retired though, but he was in Oklahoma City. And there was another clinic in eastern Oklahoma. They did a fabulous study that found that IC was more common in people of a Cherokee Indian descent. That was fascinating. But they're both retired now. It's really hard to maintain doctors list. We do have a doctors list on the IC Network website. I still go to the top doctors in the country. If you're willing to travel, you can go see Ken Peters in Michigan, Robert Evans in North Carolina, Robert Moldwin in New York. Dr. Robert Eckenberg, who is the best pelvic pain doctor in the country. In my opinion, he is retiring at the end of this year, but he is continuing to work with patients by phone and on internet after he retires. So he's going to be a great second opinion for lots and lots of people. Fabulous doctor. Oh, and I was talking with him yesterday, and we were both very, very frustrated about the lack of pain care that's being provided. I had a patient a couple weeks ago who had a hysterectomy, a rectocele repair, and a bladder lift, and she was denied all pain meds. My answer to that when I work with patients is I say, you have to talk about it at your pre-op appointment. Will you provide pain care? And if they say no, I generally, what I've said every single time, to be quite honest, and realize I was the chair of the California Pain Conference several years ago. If I have a doctor refuse to provide pain care, I will not do a procedure with him. I will not do it. After my hysterectomy, my pre-op for my hysterectomy, I told the doctor, what's your plan for pain care? And he's like, oh, we'll give you something after the procedure. And I said, with all due respect, I don't trust the hospital staff. I want a prescription in my hand. I want to know what you're doing. And he's like, not a problem. and he gave me a prescription for Vicodin at the time. And just last summer, I've had 2 surgeries this year so far. Both times, I want pain meds. And the surgeon, when I brought this up before my mastectomy, she said, "I wouldn't do it without pain meds, honey. I'm giving you pain meds." And she gave me a week's worth of Norco. I used it up. I called back and she gave me another 3 or 4 days of Norco, and that's all I needed. And I think you can say, listen, am I going to become an addict if you give me 2 or 3 days of Norco? I think we all can agree, no, that's not going to happen. Having a hydrodistension so that they can treat Hunner's lesions is a traumatic procedure. It is completely normal to have a little bit of pain meds for a day or 2 afterwards to get you through that post-op recovery. So the way I would talk with them is say, listen, I'm not asking for a month's worth. I'm asking for 2 days worth of Norco, 3 days worth of Norco at the most. Can you and I agree that I'm not going to become an addict with 3 days of pain meds? And the tragedy goes back to the Center for Disease Control and their guidelines for opiates, which has, done so much damage. So I think, what did she say here? I canceled my injections because of no pain man. I would have done exactly the same thing. And so if you have Hunner's lesions, are you aware of the new lactoferrin research? I'm working on an article on it right now for our website. So in August, we had a new IC study come out that was using lactoferrin. Lactoferrin is a protein found in colostrum. It is a protein found in all of our secretions. We have lactoferrin right now in our tears, in our saliva, in our seminal fluid for men, in our vaginal fluid for women. Lactoferrin is a protein that has a natural antibacterial, antifungal, an antiviral effect. The way it works is it consumes the food the bacteria need to grow, iron. It controls iron production. And so lactoferrin plays a critical role in the development of the immune system in babies, but they have been now testing lactoferrin in the treatment of a number of medical conditions in adults. And so in August, a new lactoferrin IC study was done in Europe, and the data was it was a solid study. And the reason why it was a solid study, and I was telling Dr. Eckenberg about it yesterday, is they didn't just give patients pills and say, let's see how you are in 3 months. They had 31 patients, all with a history of IC symptoms and flares in the previous 6 months. They took blood tests to measure their inflammatory markers, specifically interleukins, and they did cystoscopies to document the health of the bladder wall. Then they gave them a form of lactoferrin for 3 or 4 months. And at the end of that, they went back. So 28 out of 31 after lactoferrin use had no IC symptoms. And when they went back and measured their inflammatory markers in their bloodstream, they were far lower. They were significantly lower. But most importantly, when they went in with a cystoscope and looked at their bladder, the red inflamed bladders had turned pink and Hunner's lesions had disappeared. They couldn't find them. Now, why would lactoferrin help Hunner's lesions? Well, we've now linked Hunner's lesions to viruses. That a Hunner's lesion is actually, for most patients, probably an active viral infection of the Epstein-Barr virus or the polyoma BK virus. And lactoferrin is antiviral. And so that's the guess as to why patients using lactoferrin report an improvement in their lesions. And so no side effects, it's affordable, and it's not for the rest of your life, it's for a couple of months. So I think what I'm saying to patients, and I can give you that study, you can look at, I'll have an article on it this week on our website. It's a no-brainer to me. It's like, you got nothing to lose because there are so few treatments for lesions. No side effects. Lactoferrin is found in the human body anyway. We just need a little bit more to boost the immune system. I think it would be a very interesting experiment. And Carol says she's on lactoferrin. She's been on it for 2 months. And you're going to go see Ken Peters, and he's going to see you in January. Okay, that's good. So, Carol, it's been 2 months since you've been on lactoferrin. How are your symptoms? Have they changed at all? Have you gotten a little bit better, a little bit worse? I've got some patients using lactoferrin who are better. But I haven't heard. We're not doing an active study on it right now. It's just when they call me, it's like, "How are you doing? Do you think you're better? Do you think you're worse?" Okay, Anita. Anita here on Facebook says, "Can you please talk about bladder removal?" Absolutely. Let's see. Hold on. So, but before we go to Anita, so Mary says she's thinking about going to London too to get the UTI vaccine. It's likely menopause, but I just can't get a treatment that works or doesn't make me worse. You also have inflammation in the bladder neck, so that's probably causing it too. Okay. So there are a couple of different types of vaccines that are currently under development and are in active testing. Euromune is one of them, also known as MV140. Kim says, is Estrone better than topical estrogen? Or no? It's more convenient. So E-string is like a little tiny round donut that's coated with medicine that you stick into your vagina, and then it delivers estrogen 24 hours a day in small quantities. I like the flexibility of being able to put estrogen cream where I need it. And so being able to put a little bit of estrogen cream at the entrance to the urethra or at the vaginal opening, to me, is very much more convenient. I did try E-string. It fell right out. And so I could not make E-string work. It's certainly more convenient because you're not going to have to deal with the cream. And it's worth a shot. See how you do with it. Yeah, Kim says, in my next life, I want to be a boy. I don't know. I mean, on one hand, we're cursed with periods for decades and decades. And that sucks to have cramps every month. But then, guys have prostate problems, and their problems kick in at older when they're a bit older. It's tricky. Mary says, where do you get the lactoferrin? In the IC Network shop. I brought it in. So we have lactoferrin in the IC Network shop. Carol says here, I think I've gotten better. Still having flares, but they seem much better. Yes, baby. Yes, yes, yes. Oh, good, good, good. That's a good sign. So let's give it another month and see how you do. Woo. I hope that works. I really do. All right. Anita wants to know about bladder removal. Okay. So, there isn't a patient out there who's struggled with pain. Mary, we can in some circumstances. I'll get to that in a minute. I remember my first year with IC, I begged my doctor to take my bladder out. I said, I don't need it. Take it out. Just get rid of it. And he said, no, Jill, I'm not going to take your bladder out until we've tried stuff. You haven't even done a single treatment yet. And they're like, okay. And we started doing treatments. And I really thank him for not taking my bladder out, for saying no, because I now know that bladder removal is a devastatingly difficult surgery with a very, very long recovery. So the thing that you've got to understand is that, and I remember my first year as a support group leader, I had a lady in Ukiah who had a bladder removal, and she was stunned that she still had bladder pain afterward. It's like, this was supposed to get rid of my pain. Why do I have pain? And her pain was actually worse from the trauma of the surgery. And that is because when we think about our phenotypes, she wasn't a bladder wall phenotype. She was a widespread phenotype, or she was a pelvic floor phenotype. Removing the bladder doesn't fix pelvic floor dysfunction. Removing the bladder does not fix very sensitive nerves. It just doesn't. And so there are patients, many, many patients who've had their bladders removed who've ended up being stunned that it didn't fix it. And it turns out the reason why it didn't fix it is because their bladder was a victim of something else that was going on. Now, in contrast, for some patients, if you look at our AUA guidelines that were revised in 2022 have a very strict set of criteria for bladder removal. The patients with the best outcome of bladder removal are the patients who have Hunner's lesions, who have not responded to therapy, and they have a small fibrotic bladder. The patients who are the least likely to respond to bladder removal who are patients who have a large bladder capacity, which tells us they have a healthy bladder, patients who have pelvic floor dysfunction or other pain conditions. And so Mary says a lot of people on removal groups are way better, though, like 99%. But there's bias in that group, hon. There's just bias in that group. That group is probably filled with patients who have success stories to share. On the IC network, we have a bladder removal discussion string. It was run by Carol, who had her bladder removed very successfully. There are some patients who are thrilled to have their bladder gone because they never have to use the bathroom. They never have to run to use the bathroom to pee. They can empty their bag at any time. They don't require a bathroom to empty their bag. But it is massive surgery. It is a year-long recovery. It takes time to get over this. And then you have to consider methodology. So for some patients, what they do is they basically just attach the ureters to the abdominal wall. You have a stoma. There's a bag attached to the stoma on the outside, and the urine just drains from their kidneys down the ureter right down into the bag. So you have to deal with the bag, okay, which is for some people not a big deal. For others, it's annoying. You have to understand that insurance, if you're considering it, you have to have a big conversation with the insurance company about what they will cover. Because I had one patient in my group, her name was Joanne, bless her soul, she's now gone. She had her bladder removed, and her insurance would only pay for 2 bags a day, but she needed 4. So she was stuck with needing to reuse bags, which will definitely increase your likelihood of an infection. That's a bad thing. Or they can take a piece of intestine and create an internal pouch. So the urine collects in the internal pouch. There's a stoma attached to that, and then you drain it from the pouch with a catheter. Of course, the challenge with that is intestine was never meant to hold urine. And so you end up with the intestinal tissue starting to break down, and you can get more infections that way. Anytime you put a catheter inside your body, you're potentially introducing bacteria into the human body. And that can be a bit of a challenge. I've worked with lots of patients who've had their bladders removed. Some it went really well. Some was absolutely terrible. And they regretted it. And they were very, very disappointed that their pain didn't get better. Mary said, "I'm considering it. It's ruined my life." So again, listen, I'm not against it because I know that there are moments when there's a place for it. We just have to make sure that all the due diligence has performed here. We want to make sure that you've been properly phenotyped. We want to make sure that we know what the underlying cause of it is. If you have Hunner's lesions, definitely want to get you tested for Any active viral infections? I was working with a patient last week or 2 weeks. No, I've talked to her a couple of times. I just talked to her again. She has an active Epstein-Barr infection, and she's had it for years. Her lesions are coming from the virus, so now she's starting antivirals. They never tried the antivirals for her. So if your lesions keep coming back, why? She had 9 the first time, she had 6 the second time. They just looked in her bladder again. She's got 3. So things are definitely starting to improve, but they're still very, very painful. And so that's because they know she has an active Epstein-Barr. She got tested. I think her next line of treatment is a very good antiviral to see if that will stop the lesions from appearing and growing. That's how much has changed, guys. You got to understand. Our understanding of IC is very different today than it was 20 years ago. Now we understand the role of viruses. Now we understand the role of bacteria. We do understand that. Danielle says she's going to cry. I'm so happy. If I can give you just a little bit of hope, I'm always happy to do that. And you're taking antivirals. Good. So the question is, how are you responding? Kim says, here, hold on. Kim says, I think people are in so much pain, they will consider anything. I would rethink removing your bladder. Absolutely. That's very true. Like I said, my first year when I was 32, I asked them to remove my bladder. Pain creates desperation, and it's very easy to grab at anything, even surgery, if there's a chance it will make you better. And it's very important that we make our decisions based upon good, sound knowledge. And that's getting harder and harder today. You know, when you go into support, I can remember, right, about a year after Facebook started, an IC patient was considering having your bladder removed, went into a Facebook group and said, should I have my bladder removed? And people thought they were qualified to answer that question. And half said yes and half said no. That's not helpful for her at all. We have to understand underlying causation. We have to make sure underlying causation is treated. And so, Mary, if you're considering it, call me this week and let's just try to do another quick phenotype and let's make sure if there's anything else that we might have missed. Danielle says, you're desperate for pain relief. So Danielle, have you tried PEA yet? Palmitoyl ethanolamide, also known as PEA. This is our new option for pain relief that's available over the counter. Hi, Sue. Hey, girl. How are you? Palmitoyl ethanolamide acts to reduce pain by calming nerves down, and there are dozens of research studies proving that it works, including an IC study that showed that 87% of patients who did PEA for 3 months reported a significant reduction in their pain and discomfort. This is what I take, because this is about calming nerves down, and I know I have very sensitive, painful nerves. And we have the IC study to back it up that came out in 2019. So you can get this on the IC Network shop. This is huge, because again, when we think about phenotyping and we think about those patients with central nervous system pain, this calms nerves down. And so this is what I'm suggesting as a first line option for patients with widespread pain. And our AUA guidelines support this, because our AUA guidelines say, try the supplements before you go to the traditional meds that have a lot more side effects. And so you consider an opiate, which has a number of risks. You consider gabapentin, Neurontin, all of which come with a host of side effects, as compared to PEA, which does not come with those side effects, is not addictive, is not associated with any great issues. And there are dozens of research studies showing effectiveness for acute pain, chronic pain, surgical pain, burning mouth syndrome, shingles, fibromyalgia, IC, pelvic pain, chronic prostatitis. There are just so many studies, very, very minimal side effect profile, no known drug interactions. So I took the IC study to an American company, Natural Approach Nutrition, and I said, can you make us an American version of what was used in the IC study? And they did. And that's this. And this is one of our biggest sellers now. In fact, I just put in a new order. We're getting a little low. I think we're down to a couple dozen bottles. So get it while you can, because we might not be able to get our production run in until late December. Yikes. I got to make sure I have some. Okay, I got one bottle up there for me because I'm almost out. I think I'm down to my last two. So that'll get me through. Anyway, Piora. Sue says, 2 months overdue for my injections, a little extra stress with caregiving mom with health this time, and my kitchen model's not going too smoothly. Oh, hon. How's your mom doing? How's she doing? Mary said, it's hard because people are left too long in pain that they are desperate. Yeah, absolutely. You know, and the irony is, what have we learned? We have learned that the more pain goes out of control, the more the central nervous system reacts, and it can become a very chronic situation. Whereas if we stay ahead of the pain, that avoids all the nervous system trauma. So if you're forcing that patient to be in high periods of pain for long periods of time, you're basically creating the perfect foundation for chronic pain to develop, for a difficult long-term outcome. Whereas if you just medicate a little bit for a week after a procedure to help that patient get through that post-op recovery without causing agonizing pain, that's better for the patient. That's a better outcome for the patient. Kim, just go to our website, icnetwork.org, and there's a link that says shop, and they'll take you over to our store website. We've been doing this for a long time. The IC Network website is literally one of the very first health websites ever built. I did it in 1993, late 1993, I was at home with IC. I'd been fired from my job. I signed up for a night class in the internet to learn more about it. And the IC Network was my school project. And now 30 years later, it's been rated the best on the web by Harvard Children's Hospital and the University of London. And it's a very large, comprehensive website that all started with me taking a night class after getting fired from my IC. Sue says, I keep going in and out on Facebook. I don't know why. It looks good on my end. I'm not having any delays at all, which is a rarity. Absolute rarity. So I told you, hold on. So Sue said she just finished her radiation treatment. Now she's done for 3 months, but she fell last night. Oh. We keep having to call my brother to come over to get her up, who's ever at the house at the time. Oh, that's so hard. My mom was falling a lot too, and even with her walker. So what would happen is she would have her walker, but she would extend her arm to grab something and she just tilt over. And the problem is that she would have one leg under the bar of the walker, one leg on top of the walker, pushing it down. And we called the fire department 6 or 7 times in the last year or two of her life because we couldn't lift her up. Like the last time she fell was really bad, and her legs were all wrapped in the walker. And anytime I tried to do anything, she screamed, and so we had to get the fire department here, and they just picked her up. They're just like, "Okay." Picked her up. Unfortunately, she was completely incontinent, and so then we got her into the toilet. They didn't want anything to do with her incontinence. They're like, "Are we done?" And I'm like, "Yes, you're done. I'm fine from here." Tony and Zoe. I went the narcotic way and I regret it every day. I'm on a very high doses of oxycodone, and getting off of them, my doctor says, is out of the question. I tried all the other avenues with little relief after 15 years. Now I have bowel issues that are absolutely terrible, and I still get bad bladder fares. Please think long and hard before using narcotics. Absolutely, Zoe. You're absolutely right. So what we're talking about is short-term narcotics after a procedure. Because before you came in, we were talking about the story of a woman who was given a hysterectomy, a rectocele repair, and a bladder lift all in the same surgery, and they sent her home with no pain care. Other than Tylenol, and she was screaming that night and the next morning when they had to get her to the ER because her post-op pain was so bad. So in your case, Zoe, and by the way, I gotta say, I had a childhood friend in elementary school whose name was Zoe, and we went to Sequoia Elementary in Santa Rosa, California. If you happen to be 64 and you went to school at Sequoia for a year or two, I'm so happy to have found you, if that's you, because she was so fun. I loved her very, very much. And I remember her, all these years later. Okay. So now, see, 15 years ago, we weren't phenotyping. You're 64, but it's not you. Darn it. Darn it. Because I would love to see her again. Oh, that's so funny. Okay. So 15 years ago, we were not phenotyping. 15 years ago, the assumption was we all had an incurable bladder disease. And so they gave patients Elmeron, they gave patients an antidepressant, they gave patients the diet, and they sent them on their way. And obviously, many were in agony, and they went the opiate route. I mean, they had compassionate doctors who said, "Yes, you're in pain. We want to help you with that pain." The problem, of course, is only treating with pain meds does not fix the underlying problem. And we have to fix the underlying problem. And so today, as an example, the number one cause of long-term intense pain in the typical IC patient is Hunner's lesions, an untreated Hunner's lesion. And we know that if that lesion gets treated correctly, the pain usually improves. But Elmeron and diet modification does not treat a lesion. What treats a lesion is cauterizing it. It's injecting it with a steroid. And now we know what causes the lesion, and that for many patients, Hunner's lesions are caused by viruses. It's a viral infection. So now we're treating lesions with antivirals. So in our phenotyping system, the second thing we're going to look at is bladder wall driven symptoms. And we're going to look for chemocystitis, which is a chemical injury of the bladder. So these are the patients whose symptoms begin during chemotherapy because the chemicals in chemo are very harsh. Or these are the patients who have been exposed to toxic chemicals in their workplace. These are the patients who might be drinking a lot of diet soda, a lot of coffee, energy drinks. The bladder is not invincible. The bladder is injured when certain toxic chemicals are introduced to it. So for these patients, we try to find the toxin, eliminate the toxin, and give their bladder time to heal. The next thing we're going to look at is estrogen atrophy. Now, you're 64. This has been going on for 15 years. So your symptoms started when you were around 49. So when symptoms begin in the late 40s, early 50s, we're always going to look at the quality and health of the skin. Because estrogen and the loss of estrogen can cause significant bladder symptoms and bladder pain. Because your bladder needs estrogen to produce that nice thick coating of mucus. And without that estrogen, the bladder lining gets thinner and thinner and thinner and thinner, which then allows urine to reach the cells and reach the nerves to cause more pain. So we always want to look at the quality and health of your skin. If your vulva is dry and your vagina is dry, so is your urethra, so is your bladder. We call this the genitourinary syndrome of menopause. And what peeves me is that millions of women have been told they have a bladder disease when they don't. Okay, now the third thing we're going to look at is pretty much what Zoe just said. It all started after a hysterectomy. Your bladder was fine before. You are a surgical injury patient. You are a surgical injury patient. So let's think about that hysterectomy for a moment, because I've had one too. A hysterectomy is a major physical trauma to the pelvis. If they did did they do a laparoscopic assisted, or do you have a bikini scar? Do you have a horizontal scar? Or did they do it all through your vagina? Surgery involves cutting muscles and potentially cutting nerves and cutting blood vessels. It is very common after hysterectomy to develop very, very severe pelvic floor dysfunction. I had, after mine, about 6 weeks after my surgery, I started getting this pulling sensation. And I can still remember, Diane, hold that thought, girl, hold that thought. I can still remember trying to put my estrogen cream in with an applicator in my vagina, and I accidentally poked the incision line where my cervix used to be, and the pain was insane. And it was so, I remember I walked out and I was like gasping in pain, and I walked into the kitchen and my elderly dad was in there, and I was just like, oh my God, I feel so terrible right now. And it's like, why? And I went, I tried to do this. Okay, so she had a laparoscopy and she had huge fibroid. Okay. So, Zoe, basically what happened to me is that I started getting these pulling sensations and pushing sensations. And sitting in the car became difficult. If I sat down too hard, I would get this deep, like there was a hand inside my vagina pulling stuff out. That's kind of what it felt like. And of course, my doctor was like, post-op recovery, post-op recovery. Jill, you just had surgery. You got to let it heal. You got to let it heal. Well, I had surgery in May. I was still having it in December, and it was getting worse. And I finally got into the doctor. It's like, what the hell is this? Make it go away. And he could see my muscles quivering. I mean, he had a speculum in there. He could see my muscles quivering by themselves. And he goes, oh, I know exactly what you have. And I'm like, what do I have? How did he describe it? What did he say? He called it post-operative involuntary muscle spasms. Involuntary muscle spasms. Muscle spasms. The muscles were doing their own thing. I had no control. And I went, okay, what do we do about it? He goes, physical therapy. I'm like, sign me up, baby. Sign me up. And he goes, well, I just want to know you. Most women drop out. And I said, well, I'm not most women. Why'd they drop out? He goes, because it hurts. And I went, I don't care. Sign me up. I'm going to do it. And so I went in the first time. And like I said earlier, I've never found hands-on physical therapy to be painful. It wasn't that big of a deal until I put my clothes on and started walking out to my car. And then when I sat in my car, I burst into tears. And I cried all the way home. And I went home and I took a Norco and I was in my recliner with a heating pad for 10 hours. Hold that thought. I went back the second time. I told her what happened. Go back out to my car. And again, sat down in my car, burst into tears again, but it only lasted a couple of hours. The third time I had physical therapy, when I went back into my car and sat down, it didn't hurt. And pelvic floor physical therapy worked, but you've got to kind of work through the pain. Now, Zoe says here, I had a horrible. Okay, well, first thing, you said you had huge fibroids. So, how did they get the fibroids out? I mean, because your cervix, I'm assuming they cut your cervix off and then they pulled it through your cervix, right? I mean, they pulled it through your vagina. Did they have to cut your vagina open to make enough space to pull it out? Because my doctor later my doctor later shared with me that he tore my vagina. And that was one of the reasons why I was having all these spasms. And I mean, it took him 8 months to tell me he tore it, but he did tear it. So what she says here is they had to cut them and quarter them to get them out. That's a lot of trauma, girl. That's a lot of physical trauma. And she said she had a horrible vaginal infection afterwards. It was admittedly overtreated. And when that finally cleared up, I was left with what the urologist said was a severe case of IC after cystoscopy. Oh, God. Yeah, but what the hell does IC mean? Are they saying you have a bladder disease because you had surgery? No, it doesn't work that way. What you have is an injury. And so the question is, what the hell's the injury? Is the injury to your muscles or the injury to the nerves? I mean, she says it was horrible. So have you had a pelvic floor assessment? Has anybody looked at your muscles and checked them? You had tears all over your bladder upon distension. So when I had mine, they did a hydrodistension at the end of my hysterectomy to make sure they didn't damage my bladder. So did they do a hydrodistension at the end to look at your bladder to see if they damaged your bladder physically? Zoe writes, it feels like nerve damage, and no, I've not had a pelvic floor evaluation. Okay. So they were able to verify that they did not damage your bladder during the procedure. But they definitely damaged tissue. They cut tissue. They may have cut muscle. They may have cut nerve. I think that at a minimum, you need a pelvic floor assessment to see what's going on with your muscles. Because remember, you've already suffered muscle injury. The way your body responds to pain is muscles get tight. That's called the guarding reflex. And the problem here is that the longer muscles stay tight, the more damage they do. Because tight muscles squeeze blood supplies. Tight muscles squeeze nerves. Tight muscles squeeze the blood vessels to keep the nerves healthy. Every nerve has its own blood vessel running with it. That nerve needs a blood vessel to operate successfully because it has to release ions and pull them back in. And it does that through bloodstream. But if you have tight muscles, that's depriving that nerve of the blood supply it needs to be healthy. So now we have neuroinflammation. Zoe says, I honestly believe they withheld the truth from me. I firmly believe that my bladder was indeed damaged. Did they take pictures? Like they took pictures of my bladder. Did they take pictures of your bladder? And okay, and I mean, just for kicks and giggles here, not that this is funny, because I know it's not funny. Can you describe your pain for us? So let me ask you questions. Let me ask you the question. If we were talking on the phone, these are the questions that I would ask you. Okay. So, concept number one is, what does the pain feel like? What's the quality of the pain? Is it sharp or dull? Or does it have a burning quality to it? Or is it electrical? Do you feel like you're being shocked? So, what is the quality of your pain, Zoe? Sharp, dull, achy, burning. So your pain is severe burning and aching inside. Okay, inside where? Is it in your vagina, in your rectum, or in your bladder, or in your urethra? And sometimes it's hard to distinguish, but this is important. This is all going to lead to something. So when we're dealing with burning on the inside, does it feel like it's burning inside your bladder or inside your urethra or in your vagina or in your rectum? Those, those all can happen. At times, mostly bladder and your urethra. Okay. When is the pain the worst? Before you urinate or after you're done urinating? Is it the worst when your bladders are really full and you feel better once you pee? Or is it worse after you're done peeing? Before. Are you diet sensitive? Does food make it better or worse? Like, can you eat anything and it's not a problem, or you have one soda or one cup of coffee and you're in pain for days? So, are you diet responsive? So, you're not diet responsive now, but you were at one time. When you go to urinate, can you start your stream right away or do you hesitate 5, 10, 15, 20 seconds before you can relax enough to release urine? Can you pee on command? Do you pee like a horse? Are you stopping and starting and no, you hesitate? Okay, so the fact that you hesitate proves that you have tight pelvic floor muscles because urination is about relaxation. A muscle relaxes, sphincter opens, and you pee, and it's virtually instantaneous. If you hesitate, that means that your muscles are not relaxing like they need to relax. Also, burning, that burning sensation actually comes from muscle. The bladder does not normally cause a burning sensation. It's the muscles because, I mean, think about when you were a kid and they made you run around the track and eventually your legs would start burning. That's like, no, it hurts. My legs hurt. Why? Because muscles that are working hard produce lactic acid, and lactic acid burns. So anytime a patient has a burning sensation, that points us very directly to muscle. You're welcome, honey. This is why we're here. I mean, I'm the National IC Support Group leader, and I love working with patients just like you. My job is to open some new doors and windows, so give you some hope here because you've been on pain meds for a long time and they've never tried to figure out the underlying problem. And now we're trying to fix the underlying problem. So you, my dear, so you're going to ask, well, then why was I diet sensitive? And why is my bladder more sensitive? And the answer is because of tight muscles causing ischemia or ischemia. That's oxygen deprivation. If your bladder is supposed to get 24 units of blood a day and it's only getting 10 because your muscles are so tight, are you going to have a healthy bladder wall? And the answer, of course, is no, you won't. So it's very common for patients who have very tight pelvic floor muscles to struggle with diet sensitivity. But once we restore a blood supply with physical therapy, the bladder finally starts to get the nutrition it needs and the bladder begins to heal. So you, my dear, desperately need a pelvic floor assessment. You should have had a pelvic floor assessment in 2011 when our AUA IC guidelines encouraged doctors to do this. And now, in our most recent guidelines for the diagnosis and treatment of IC, they're supposed to check your pelvic floor at the very, very first appointment. And if you have tight pelvic floor muscles, as you do, you are to be referred immediately to a pelvic floor physical therapist because pelvic floor physical therapy works. And we have the research to prove it. Pelvic floor physical therapy outperforms oral treatments 2 or 3 to 1. And that was the moment that the IC world changed when we had the release of the study in 2008 that proved that pelvic floor physical therapy worked. And that was the moment everybody went, uh-oh, maybe this isn't a bladder disease. Maybe this is actually something to do with muscles. And now, fast forward to 2024, we now realize that 85% of IC patients are actually neuromuscular patients. But honey, listen, because you've had this for a long time, and because your case is complex because of your surgery, you need to go to a properly certified pelvic floor physical therapist. And there's a website where you can find them. I'm going to put it in the link here, pelvicrehab.com. Go there. That is an online database from the Herman and Wallace Institute that certifies physical therapists in pelvic floor work. And that's the best way to find it. And it is covered by some insurance and not by others. If your insurance doesn't cover it, pay for at least a pelvic floor assessment out of pocket, because this is vital data here that will help us understand why you're struggling with such high levels of pain. And then if they do find that your muscles are tight, as I think they're tight, you can then explore muscle relaxation, muscle relaxant. That a pelvic floor skeletal muscle relaxant in combination with physical therapy might resolve the great majority of your pain. Because now we're working with the underlying problem, because you are a surgical injury patient and you're not the only one. Your symptoms began immediately after surgery. So that's not a disease. Now, the other issue you got to understand is you are in estrogen atrophy. You are in menopause. So your skin is going to get dry. Your skin is going to be very dry. And so that's a second thing that is messing with everything. And so again, if your vulva is dry, your vagina is dry, so is your urethra, so is your bladder. We've got, we women, you got to pay attention to your skin health down there. We want to keep that skin moist and healthy. And so normally at the age of 64, you would probably be using a topical estrogen to keep that skin moist, and maybe something like vulva balm on the outside to act as a barrier. Well, look, there you go. She says, I'm very dry. I use organic coconut oil. The challenge with coconut oil is it soaks through everything. We have something better than that. Vulva balm. Vulva balm is it's organic olive, avocado, and sea buckthorn oil, and it's a lot more soothing than coconut oil. It's in the IC Network shop. This has been thousands of patients use this very, very successfully. I've used both. I've used the coconut oil. The problem with the coconut oil for me, and it just led to intense embarrassment because I didn't realize it was soaking through my underwear. And so there would be an oily spot underneath my butt. And I remember I was wearing a dark blue dress walking around and it looked like I'd had an accident. So it's in the IC Network shop. Just go to icnetwork.org and go to our shop and you can order it there and it'll ship out tomorrow. And then buying it from us helps support this chat, All right. Karen says, what's my opinion on Hyprax? Formaldehyde concerns me in the product. Hyprax is not a treatment for IC. Hyprex is operating on the assumption you might have some sort of low-grade infection, but most IC patients have no infection at all. And so again, we go back to your phenotype here, Karen. If your symptoms began in your 40s, 50s, then you're probably going to be like Zoe in the sense that you're going to have some estrogen atrophy driving these symptoms. And Hyprex will do nothing to correct estrogen atrophy. It is a perfect example of a fake out. It might help suppress some of your symptoms, but it's not going to repair anything. And we have to focus instead on finding the cause of your symptoms and then trying to fix the underlying cause. So Hyprex to me is completely pointless. All right, going back over here to YouTube. So Danielle, honey, again, Peora, you got nothing to lose. I think putting a Peora on board to calm the nerves down might help reduce some of your pain. Diane says, I've been miserable with bladder pain since a couple of years after menopause, and I've been on estrogen for 2 years, and it helps some, but not off. Okay, so in your case, honey, listen, even with topical estrogen, we're never going to have a 20-year-old bladder. We're just not. And so there are some patients who just need a little bit more protection from the bladder wall. And so that's where a chondroitin-based supplement would apply. So you could add bladder builder or bladder rest or cystomend or cystoprotect. Those are all chondroitin-based supplements. Chondroitin is a building block of the bladder wall that's essential to the superficial integrity of the bladder wall. And so if the estrogen doesn't work or is not getting you where you need to be and there's room for improvement, the next step is going to be a chondroitin-based supplement, seeing how you do with that. Lots of patients do it very, very successfully. I have a menopause guide in our shop that explains the hows and whys of it. And then if that doesn't work, then you could go to a rescue installation or heparin installation that would put a physical coating in your bladder to protect your bladder. But, again, this is about understanding the anatomy a little bit more. You're never going to have a 20-year-old bladder. And so it's great that you're on the estrogen. It just might not be enough. But something like, let's see here. So these are the best sellers in the IC Network shop. Bladder Builder is, in my opinion, the best supplement that we have because it has more ways of helping. It also includes PEA to reduce pain. Bladder Rest is kind of a starter formula for patients who are very, very sensitive and you have so many reactions, you don't want to take anything. So it's a very kind of clean, pristine, simple formula. And then Cystomend is like the bus effect. This is a very robust, stronger formula that provides more of a coating effect. But there's a lot of ingredients in this, including D-mannose, among other things. Let's see, this has chondroitin, L-arginine, quercetin, glucosamine, D-mannose, rutin, and PEA, along with olive leaf extract, etc. So this is using the olive oil base, where the others are using an avocado oil base. This is, in my opinion, I think the most effective one. We did a 1-year follow-up study that was very encouraging. What is it? My hair is being so weird today. I washed it, but it's getting dry. It's annoying. Sue says, is there any research on doing Botox injections in the pelvic floor twice a year for several years, causing more problems, or just anything that I might not know about getting them now for about 3 years in a row? Well, I mean, Sue, you got to remember that your pelvic floor is badly scarred, right? And so is Botox gonna fix a scar? I mean, because you had that, and we've talked about this over the years. So she would, I'm sure this is fine. So Sue was a very competitive cowgirl, and she was in horse shows. And if I remember correctly, weren't you a barrel racer? I might be wrong, but she had a very, very, very bad fall. And so, what makes her case so interesting is that when she did physical therapy, it always hurt in one location. And for most people, physical therapy slowly but steadily improves the muscles. But oh, you were off trail riding and training? Okay. Horses hit the ground a lot, but also had an unnecessary hysterectomy and pelvic floor reconstruction. Okay. I might be confusing you with somebody else, but the whole horse thing, falling off a horse, that's definitely part of the picture here. So, but didn't Dr. Peters find a big knot of scar tissue in your pelvic floor? Mary says, installations made me worse and no IC treatment has worked for me. Mary, you need to be phenotyped. If installations made you worse and no treatment has worked, what our guidelines say is stop what you're doing, take a step back, and revisit the diagnosis. We need to understand what's going on in your pelvis physically. Call me this week. Call me. I'd be happy to talk with you. Let's see if we can try to narrow it down a little bit. You're not alone, girl. You're not alone. But you got to be properly phenotyped. Kate, let's see. Diane says, I've been okay. I take 2 Cystomen capsules daily. Would oral hormone replacement help some more? Well, it depends upon your age, honey. It depends upon your age. Oral estrogen is associated with a greater risk of cancer. And we don't want that to happen to you. Take it from somebody who's just going through that right now. We do not want you to have the mastectomy that I had. It's a beast. And so they really only prescribe oral estrogens if you're like under the age of 50, maybe under the age of 45, and struggling really badly with early menopause symptoms. But generally, if you're over the age of 60, they do not want to prescribe it because the risk of cancer is quite high. In contrast, topical estrogen is not associated with any great risk of cancer. And so the topical estrogen is what we would normally be doing. Kate says, infection, more likely bladder muscular pain from urinary retention. I have many years long spinal injury from childbirth. I agree with that. I agree with that. Sue, I apologize if I got if I got your case wrong. But getting back to your question, is doing Botox twice a year for several years causing more problems? You know what? Let me look. Let me look. Let's see if there is. I'm just searching National Library of Medicine for long-term Botox use bladder. Here's a long-term adherence to Botox intradetusor injections for neurogenic dysfunction in children. That's from July of this year. 54 patients. Follow-up was 10 years, up to 10 years. The average treatments was 6.4. 7% did not need Botox anymore. 76 discontinued therapy. %33% changed to different therapies. May consider Botox a safe and effective therapy for pediatric patients. Treatment abandon rate is higher for children than for adults, but no specific reasons were highlighted. All right, here's a study from March. Efficacy and safety of low-dose Botox in female patients with overactive bladder. They say there's significant improvement in the short term, but with a subsequent decline over time. But with overall improvement compared to baseline in the long term. Safety assessments revealed manageable adverse events in both groups, but they don't talk about it in the summary. I don't see a study that would answer your question, honey. I do not see that. Diane said, I'm 59. My mom took oral HRT from the age of 46 to 76 and did good on it. She had cancer to the salivary gland and colon, but not any estrogen cancers. I'm willing to try anything. I'm desperate. All right. So my mother was the same. She took it from like the age of 50 all the way up to the age of 90. And she had no issues with it at all. And so because she had no issues with it, I decided to take it. I thought my risk was low because my mother had no issues. 3 years later, I started spotting and I needed a hysterectomy because the oral estrogen had caused my uterine lining to grow and change and become precancerous. And now I've had breast cancer. So Diane, I want to make you this offer. If you call me this week, let me try to phenotype you. Let's see if we can find the underlying cause of that pain. Let's not just assume that it could be related to estrogen atrophy. My phone number is right there. 800-928-7496. If you call on Tuesday, Mondays are my day off because I work on Sundays, obviously doing this meeting. So I usually have my Mondays off until later in the afternoon. And then I start answering the phone. But then I'll be going gangbusters on Tuesday. And I'm happy to talk to anybody. I mean, listen, my job is to educate you, inform you. I get to spend a lot of time with you that your doctors can't. And then we end up with a new set of questions for you to ask your doctor. And Mary, that's fine. If you have a long story, what I'm going to do is I'm going to ask you a lot of questions first. So you just have to let me quiz you. Because I can do it very quickly. It only takes me 5 or 10 minutes to do a successful phenotyping. Marilyn said, just diagnosed with lichen sclerosis and inflammatory genital skin disease. I'm so afraid of how this is going to affect my IC. Stress is a major factor for both. I'm mildly diet sensitive. Ugh, what next? So Marilyn, very common. Lichen sclerosis is very common. I'm very, very familiar with it. Did they give you clobetasol? They should have given you clobetasol, a steroid cream to use. I really think that lichen sclerosis, what makes lichen sclerosis so interesting, and my mom had lichen sclerosis too, is that the skin turns white. We start losing blood supply. The skin gets very, 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 very pale. And I'm of two minds with lichen sclerosis. I believe that Very, very tight pelvic floor muscles start to restrict too much blood supply, and that can affect the vulva. And that would help us understand why the tissue does not appear, I mean, the tissue gets so pale. And then also a neuroinflammatory process. Neuroinflammation is definitely going to be playing a role here. Ah, my neck gets so tight. Ah. Mary said, I take any risk now. Seriously. Mary, now listen, you cannot make your medical decisions based upon that. We've got to take a step back from being frantic. And we need to be a little bit more logical here. And that's my job. And so just if you can just hang tight, let's see if we can talk and maybe we can identify a better treatment target for you than what you've done before. And remember, that's what our AUA guidelines say. Our AUA guidelines say that if you're not responding to treatment, if you're getting worse rather than better, stop what you're doing, take a step back, revisit the diagnosis. What have we missed? Because obviously they've missed something because you're not responding to bladder treatment. Diane says, I'll give you a call again. We've talked before, and I fall into the widespread pain, pelvic floor, estrogen atrophy. You're back in physical therapy on Friday. Good. Good. Yeah, you just have to be patient. Listen, pelvic floor dysfunction has often been there for decades. 3 or 4 appointments is not going to fix that. This is about retraining muscles to be normal again. It's about retraining muscles to be relaxed and released instead of tight and painful. And you're probably going to be in physical therapy off and on for an extended period of time. But more importantly, hopefully you're learning how to do it at home. Hopefully the physical therapist has had you buy a wand and they're teaching you how to use the wand. I used my wand 2 nights ago. I always know how my muscles are doing based upon how I'm peeing. And if I'm having moments where it almost feels like my perineum is numb because it's very, very tight, that's when I know my muscles are tight. And that's when I go in there and I do my wand and I work on those muscles myself and I nip that sucker in the bud. Sounds good. Sounds good. All right, guys. Well, listen, we've been going for 3 hours. 3 hours. So what's happening? I just put a big new video up on our YouTube channel, which was the presentation I gave on Friday for a Canadian pelvic pain group. Very proud of that. It was a really good presentation, did really well. What else am I working on right now? Working on some clinical trials. Working on a new lactoferrin article. I'll have a newsletter going out probably at the end of this week. And when I say newsletter, listen, our newsletters are ginormous. They're like 10 or 12 stories. So they're like mini books. And so you can get that for free if you just go to our website and sign up on our newsletter list. We also have a magazine, the IC Optimist Patient Magazine, that goes to our members. If you like these meetings, it's just $25 a year to get it by email, $50 a year if you want us to mail it to you. And that's what keeps my doors open so that I can keep doing these work. My goal here is I want to keep working for another 10 years. See if I can make it to 74. But I've never felt closer to death than I have in the last year with a breast cancer diagnosis. They got it all. They say they got it all. The lymph nodes were clear. The surgical margins were clear. But I'm having trouble recovering from the trauma of it all. Physically, mentally, and emotionally, it's been a very, very difficult year for me. You too, honey. You have a great rest of your evening too. Diane said, okay, here, hold on. Kate said, I'm a newbie to chat. I'm reducing acid in drinks, flavored water, and I need to a cream from the IC site. Anytime, honey, anytime. One secret on the IC Network shop is if you go to the bottom of the front page, you'll see that I wrote a bunch of guides based upon condition. So for patients with pelvic floor dysfunction, I go through the products we would recommend for that. For patients with genitourinary syndrome of menopause, estrogen atrophy, I go through the products for that to give you some ideas. And of course, you're always welcome to call. I work on a first come, first served basis. Please know that if you call and you get my service, that already means I'm working with somebody. Please leave your name and number. And also know if you're on the East Coast, I tend to call back late because I usually work until 5, at least 4, if not sometimes 5 Pacific time, which might be 8 your time. And some days that's all I do is I'm on the phone 7 hours, 8 hours a day until my voice gives out, which is never good. But I'm always happy. I'm always happy to talk with patients by phone. Okay. All right. We're going to call it here. Hey, by the way, you guys, I went to the store this morning because I ran out of my low fat butter and I needed some butter for my toast. And people are already putting up their yard Christmas decorations. And I'm like, yes. It's like the best part of the holidays to me is just decorating. So I thought, one house in my neighborhood, man, they had giant snowmen out and all their lights out. And it's like, yes. So I already have my year-round lights up. I have app lights. You can get them from Lowe's. They have programmable colors. And so there's like 50 different, no, maybe not 50, maybe 25 different color schemes. So they've got the pink for Valentine's. They've got all these Christmas ones, all the different colors. They're LED lights. So right now I have my yellow gold lights up for Thanksgiving, and then I'll switch it over to the Christmas light show. My favorite colors are the Valentine lights, which are pink and red, alternating. Love. So I am hoping that I still can't lift stuff, and my yard is a mess because I haven't been able to garden. And I'm single and I'm not caring for anybody anymore. Before I always decorated my house to a T because I wanted my parents' last Christmases to be very, very good. And so I'm very proud of what I did. But now when I decorate, I'm decorating for me. And I love to decorate. And so the Christmas tree is going to come up soon. And I want to get my outdoor Christmas lights up. We have a big 4 days of rain coming, though. So it's not going to be this week. It's going to be next week. Get my inflatable snowman. I have a giant inflatable snowman. He's like 2 stories tall. But I want more lights. Like I want to put a string of lights around every window. And my current lights they're like 10 years old. They're going to give out soon. I want to go back to the, icicle lights, because I have a point in the middle of my house and it's so pretty when you put those lights on it. I just need an electrician. I need more outlets on the out. I don't have any outlets on the outside of my house. That's what sucks. I've got to bring them all in from my backyard. And I guess what I need to do is hire an electrician to put more outlets on the front of my house. Man, listen, if I could do 1,000 lights on the front of my house, I would do it. I just love Christmas lights. I mean, if we can just lift somebody else's spirits and lift our own spirits, I say power to you. So for those of you who decorate for Christmas, get ready. It's getting close. I'm excited. All right. I'll talk to you later. I'm going to say goodbye to YouTube first. Bye, you guys. Have a good one.